sir, if you lose your body weight, you can actually reverse your diabetes. That really motivates the patient to go for a good therapeutic and diet lifestyle changes. So C-peptide is not only a great test to decide whether to start insulin, when to start insulin, what type of insulin to use, but also to tell the patient about the nature of their diabetes, whether diabetes reversal would really be possible or not. So it's a great test. It's a cheap test. In commercial labs, it costs around 500 odd rupees. In your centers, it may be even cheaper also. Do it the right way, please. Please do it 1 hour after a mixed meal is the best way to test the C-peptide. And please maintain cold chain if you are transporting the sample to some other lab to do the testing. Urine C-peptide to creatinine ratio, I'm sure will pick up soon in the future. And I really pray we have a high sensitive C-peptide assay available with us in the near future. I think with this, I'll end my presentation. Thank you so much.
Thank you, Dr. Deep Datta. It was a very nice presentation. You have covered most of the aspects of C-peptide, how to collect the samples, prognostic, can it be used as a prognostic marker, a diagnostic marker, how to select patients based on C-peptide level, whom to give insulin, who will respond or who will not. So we'll have this question answer session at the end of all these 3 talks. So I request my co-chair to introduce our second speaker so that we can go ahead with the second lecture. Thank you.
Good evening all. After this excellent talk by Deepta regarding that pragmatic use of C-peptide in differentiating different type of diabetes, what we see in our day-to-day practice, to differentiate the gray to white and black, and to help us to determine the treatment of different diabetic patients. Now we are all excited to listen from one of the senior teacher of our country, Professor Rakesh Shohar sir. Can we have the slide please? Sir is a senior endocrinologist, professor and head in Department of Endocrinology, Osmania Medical College and Hospital, and also attached to Shahar's Endocrine and Diabetes Center. Sir has been the president-elect in Endocrine Society of India and had chaired the many important positions in different academic societies all over the India and world. Sir has got the fellowship of American College of Endocrinology in 2009 and RSSDI for 2015, Indian College of Physicians in 2006, Indian Academic of Clinical Medicine in 2008, and Sir has numerous publication and citation in various peer-reviewed international journals. So without wasting any further time, I will request Professor Sai to kindly start. Thank you, sir.
Thank you. I'll share my screen. I would like to thank the chairpersons for the kind words of introduction, and also would like to thank the organizers, the Bengal Diabetes Foundation, for inviting me to be part of this this important conference, the Bengal Diabetes Conference. And I've been here from yesterday, and I found the talks to be the topics to be extremely useful and clinically relevant. And I congratulate Dr. Amitabh for the excellent presentation, excellent organization of this conference. So this topic that I've been given is in this session is supported by Roche. So what I would be discussing is about the fallacy of using HbA1c alone in managing diabetes, how it should be complemented with SMBG, and how this works very well is what I'll be discussing in the next 18 minutes or so. So if we look at HbA1c, HbA1c has been the gold standard for the management of type 2 diabetes for the last 30 years. I would say from the time the results of the UKPDS and the DCCT came out in the early 90s, they have actually made a big impact in terms of our understanding about the role of glycemic control in managing patients with diabetes and how we could reduce the risk of complications. The UKPDS showed that every 1% reduction in HbA1c results in a statistically significant reduction of 37% in the microvascular complications and 14% in myocardial infarction. So that, and again, the the DCCT again showed a similar result that on the average, every 1% reduction in HbA1c brings down the risk of microvascular disease by about 30%. So that actually made HbA1c the gold standard. And then since then, we have been using HbA1c as a gold standard for monitoring glycemic control. And we have in fact sort of used whatever assays we used are traced back to the DCCT assays to give us a information that what we are doing is on the right, that we are on the right track. So if you look at HbA1c, it has several advantages. It is predictive of vascular complications. There's a huge amount of data available from I would say millions of studies across the globe, which have looked at HbA1c and the correlation with microvascular complications and the macrovascular disease also, and they've shown that there is a very good correlation, and that becomes a gold. I mean, that has remained as a standard test for measuring glycemic control. It makes very good. It gives you very good help in terms of making management decisions regarding therapy that has to be used, the way we have to start insulin, when we have to start insulin, when we have to use monotherapy, when combination therapy is going to help. So in all these management decisions, it is a very useful tool, and it is also easy to measure. It is relatively cheap. It is costly in doing the blood glucose measurement, but as when you compare it with many other tests that are required, it is relatively cheap, and it is because of its robustness in terms of the use in the last 30 years. It has become a very good test which has quite a good robustness in terms of understanding the risk of complications. Although we still have problems in terms of standardization of HbA1c across our country, but I would say that over the last 1 decade or so, we have achieved a lot, and we have moved quite significantly forward. Now, HbA1c has several limitations. I'm not discussing about the limitations in terms of the standardization and the quality of HbA1c assays available. I'm speaking of, when HbA1c, we have got a reasonably good, reliable HbA1c assay. Even then we have problems with HbA1c. So that is the point that I'm trying to make here, is that when you're using quite a good HbA1c, which is from a reliable source, using a good standard method of doing HbA1c like the HPLC or the affinity chromatography, what we see is that it still has problems. One is that it provides only an approximate measure of the glycemia. You do not know the glycemic status at that point of time. So that becomes a major problem in terms of deciding what type of therapy is to be used, what immediately has to be making immediate therapy decisions or making immediate changes in the medications. You require, in addition to HbA1c, you require more information that is probably provided by doing SMBG. And it is unable to address the glycemic variability or also the risk for, it is unable to detect hypoglycemia when it occurs. So that is something which is a major limitation of HbA1c, that it provides an average level of the last 3 months. So it does not provide us information of what is happening around that mean, because there may be a lot of fluctuation around that mean, but that is not seen by the HbA1c alone. So therefore, we need more reliable tools to understand that. It is unreliable in presence of renal failure, when there is hemoglobin abnormalities, the hemoglobin S, sickle hemoglobin, or thalassemias, and all those conditions also, there may be errors in measuring HbA1c. Now, so that's why it's important to monitor blood glucose levels, because they show us the changes during the day, and these glycemic fluctuations. We also know now that we have more reliable ways of measuring the glycemic fluctuation, we also know that whenever there's a rise in glucose level, that is dangerous. Even when there's a rapid fall, then there is an oxidative change induced, and that oxidative change can lead to damage to tissues. So this is how, you could have fluctuations across the mean and around the mean, and that could not be picked up by HbA1c, and that could have serious implications. Now, HbA1c is what we see is that there are limitations. These limitations which we are speaking about is like if you're looking at, it does not indicate the glycemic variability. The magnitude of excursions that a patient may experience during the day are not shown by that. And therefore, this is one important parameter that is not assessed by HbA1c, and that has come out once we have got better tools for monitoring glycemic variability, like the continuous glucose monitoring systems which are available today. Now, to illustrate this very clearly, I would show you I would like you to look at these two patients on the right side. There's a subject 1 who's got both these subjects have an HbA1c of 8%. That is, their average blood glucose levels have been 8% in the last 3 months. And if you look at the subject 1, he has a different pattern as compared to subject 2. And as you can see, subject 1 has very high glycemic variability, has got almost 8 to 10 episodes of in that small, in that window which we're seeing of, say, maybe a couple of days. We are seeing that there are significant glycemic excursions, there's significant peaks. In this picture itself, we can see about 8 peaks. And then there are significant periods of time when he has developed hypoglycemia, almost going down to less than 50, which is quite severe hypoglycemia, developing on several occasions. And if you look at subject 2, on the other hand, he has the same HbA1c level of 8%, but with much less glycemic variability, showing that his glucose levels are almost around that mean of about 160 or 150, 160. So this shows that there could be an error in picking up the glycemic variability. We may not pick up the glycemic variability. And apart from this major limitation about not being able to identify glycemic variability, we have got other problems, like you may have falsely low HbA1cs regardless of the assay method. I mean, that is, if you're using a good assay method, in spite of that, you may have falsely low HbA1c when there is a shortening of the lifespan of the HbA1c, as happens of the RBC, as happens with acute blood loss or hemolytic anemias, or also with the use of some medications which are used for treating patients with HIV infections. Then you could have falsely high HbA1c levels in patients who have got iron deficiency anemia, who have got hypertriglyceridemia, hyperbilirubinemia, uremia, and those using high doses of acetylsalicylic acid. And similarly, the assay method can have also an effect on the on the measurement of HbA1c, as can happen with various hemoglobinopathies and those which increase the RBC turnover. And use of blood transfusions can also give rise to problems in the HbA1c results. So apart from these, so how do we overcome this? So the best way to overcome this is to complement the HbA1c with the SMBG, because HbA1c provides very valuable information. If you complement it with the SMBG, that makes it very good, because SMBG provides a real-time measure of the blood glucose levels. It provides patients with instant feedback of what is happening based on their, the effect of various foods, the effect of various exercises, whenever there's a stress or any type of medication change that is happening. Immediate feedback is provided, and this can help clinicians and also patients in fine-tuning their schedules and also the medication use. So SMBG can provide information about hypoglycemic episodes. It can help in identifying postprandial peaks in blood glucose levels, which can happen with different meals. And this can actually aid very much of deciding therapy. And if you look at the benefits, so this is one interesting study which I want to highlight here. In this study, what they looked at is that they looked at the risk of complications. If you look at the risk of complications, it's about, you can see the list of, the risk of complications, cardiovascular complications is about 6.8%. Is there any problem? Am I audible? There's some disturbance. Okay, so what I was saying is that when you look at the risk of complications, cardiovascular complications, 6.8% without, in patients not doing any SMBG. If you look at patients doing at least one SMBG per day, they showed that there was a 10% reduction in the risk of cardiovascular complications. Similarly, food complications, eye complications, renal complications, whatever you look at, there's at least a 10% reduction with SMBG done even once a day. So that is the great benefit of doing SMBG, advising patients to do a SMBG at least once a day. And you could see the cost difference that is provided. In the same analysis, what you see is that if you look at the costs over 10 years for managing these complications, and if you are expecting a 10% reduction in these complications, if you look at the cost, that comes down so much. And if you factor in the cost of doing the test, also with the cost of the meter and the cost of the strips over the 10 years, doing it once a day or 7 times in a week. This is the difference in cost. Almost a saving of 1 lakh rupees over a 10-year period. You have saved so much of money after factoring in all the costs of doing the SMBG. So clearly there's a benefit of doing SMBG, and this is shown not only from this one study which has tried to monetize the benefits, but also if you look at various controlled clinical trials, a meta-analysis of several trials, observational studies, and 10 clinical practice guidelines and all that. If you look at all this, you find that there is a use of SMBG had a positive impact in terms of achieving glycemic control and providing definite therapeutic benefit in terms of deciding the therapeutic changes that are required. Now, let me just show you some of the studies which have looked at doing SMBG and seeing the benefit of SMBG. This is the Y-weight program, which is quite popularly known by everybody. This is a real-world clinical practice data on looking at how intensified SMBG has helped in.
Sorry to interrupt you, sir.
In terms of achieving favorable weight loss.
The slides are not moving.
Slides are not moving?
Problem, right, sir. We are just seeing on. No, sir. I think some problem is there. Kindly check.
Which Rakesh,
the slides are blank. That earlier slide.
Rakesh, Manoj, the slides are blank. You want to stop and start sharing again?
Yeah, maybe okay, I'll stop sharing and start again. Sorry for that. Is it seen now?
Yeah. Yes.
It's fine, sir, now.
Yeah. Fine, sir. So what I was saying is that if you look at the Y-weight program, and if you look at patients who were on different tertiles of SMBG measurement, so if you had the lowest tertile, which on the left, which looked at patients doing it about 2.3 times per day, versus the one in this group of patients doing it about 5 times in a day. So if you look at the difference between these, there was a significant difference in terms of the achievement of weight goals and reduction in their BMI and the A1C control that they achieved with that. So this shows that the graded SMBG, doing it more frequently, even doing it once a day, we saw in the previous study that it made a significant economical benefit. And when you do it more frequently, you have that additional benefit. And this is a prospective 18-month trial which had shown that by doing SMBG, you could identify the postprandial peaks, correct them use appropriate therapy to reduce postprandial hyperglycemia and bring about a change in the carotid intima media thickness, because that's clearly affected by the SMBG, the postprandial glucose levels. So it's a very important tool which helps both in patients with type 1 diabetes, type 2 diabetes. It helps in optimizing the insulin treatment in patients who are treated with insulin. It provides for help in also in adjusting the therapies, and also helping in patients in understanding their lifestyle changes. And different studies have shown this benefit, and you could achieve near normal glycemic control without increasing risk of hypoglycemia with the appropriate use of SMBG. So even in patients who have got very high HbA1c levels, you could achieve a better control with the use of a structured SMBG. You could get the benefit in terms of optimizing the physical activity goals. Nutritional goals can be optimized by using SMBG and providing a feedback, because it provides a feedback to the patients in terms of this information. So to take full advantage of SMBG, we should establish a glucose profile, collect data at appropriate times during the day, recognize the readings that are outside the target range, and take actions to improve the glycemic control. So this is very important, because if the patient is doing this, then only the benefit of SMBG is seen. Otherwise, if a patient is just randomly doing the SMBG and not taking any action on that, not taking appropriate action, then probably the benefit is not seen. So if you have to instruct your patients to do the SMBG, you need to tell them to record these readings, establish this glucose profile, and then take corrective actions so as to achieve the HbA1c and achieve the better targets that we're looking at. And also pattern recognition is very important. So that's a systematic approach to recognizing the glycemic patterns within the SMBG data and then taking appropriate action based on these results. So you need to educate patients on establishing both pre-meal and post-meal glucose targets, gather these data, and also look at their carbohydrate intake, their insulin doses, their activity schedule, and the physical and emotional stress that they're going through. And this will, when you analyze this information, that will help you in making appropriate decisions in terms of providing better control. So if you look at the recent AD recommendations on SMBG, they've highlighted the importance of combining the results of SMBG along with A1C and CGM in appropriate patients where it's required. And they've highlighted the fact that major clinical trials of insulin-treated patients have included SMBG as a part of the multifactorial interventions to demonstrate the benefits of intensive glycemic control on reduction of diabetic complications. They have also highlighted the fact that SMBG would help in guiding medical nutrition therapy and physical activity, preventing hypoglycemia and adjusting the medication. So SMBG has a significant role in terms of doing all these, providing all these benefits when it's complemented well with the HbA1c levels. Even the RSSDI and Endocrine Society of India in their guidelines have highlighted the importance of SMBG as a very important tool in monitoring glycemic control. They have highlighted that HbA1c complements with HbA1c, and they have also highlighted the fact that it can be used for hypoglycemia prevention, recognition and treatment of hypoglycemia, and in patients who are treated with insulin. And they've recommended at least once a weekly monitoring of SMBG. And they've also mentioned that the ideal would be to do 7 times per day, but at least once a day in insulin treated patients has been advised in our own ESI Endocrine Society RSDA guideline. So I would to provide all these benefits, Roche has also actually come out with an integrated personalized diabetes management platform, which is a digitally supported and structured concept with the to provide this structured SMBG and where the data which is collected is integrated into the management software, and it helps in the physician in collaborating with the patient in coming up with important therapeutic decisions. So I would like to end by saying that SMBG is an essential component of the modern diabetes management. It complements very well with HbA1c testing, as it can differentiate the fasting, preprandial and postprandial hyperglycemia levels, detect the glycemic excursions, recognize and contribute in monitoring the resolution of hypoglycemia, and provides immediate benefit, immediate feedback to the patients about the effects of blood of their food choices, the activity that they're doing, and the medications which they're using for achieving the glycemic control. SMBG facilitates patients and healthcare providers to adjust their therapeutic regimes in response to blood glucose values and regulate the dietary intake, physical activity, and insulin doses to provide improved glycemic control on a regular basis. Embedding these SMBG values into a digital platform like the IPDM have proven to provide a benefit to insulin-treated patients with type 2 diabetes and their physicians. So I would like to conclude by once again saying that HbA1c remains the gold standard for managing diabetes, but it has to be complemented with SMBG where required, and currently with CGM where indicated in a few patients where it is going to be very useful in terms of making these decisions in their day-to-day management of diabetes. Thank you all for the patient hearing.
Thank you, sir. Thank you for your excellent talk regarding not only the various pragmatic measures that we have in our armamentarium to not only diagnose and for the monitoring of the day-to-day diabetic control for the patient, and the role of SMBG in day-to-day practice in a country like India, where the more like advanced or the newer techniques like TIR, which is not practically affordable for all the patient. We cannot do that in all the patient. So with this excellent talk, I will ask my co-chair, request him to kindly introduce the third speaker for the session, and all the question answer we will take after the third talk. Thank you.
Good evening. So for the third talk, we have Dr. Manoj Chawla. Can I have his introductory slide? I cannot see it. Okay. Dr. Manoj Chawla, just I cannot see actually. Dr. Manoj Chawla is a director and consultant diabetologist at Lina Diabetes Care and Mumbai Diabetes Research Center. He is based in Andheri West. He is a consultant diabetologist also working in SL Raheja Fortis, Mahim. He is the founder president of United Diabetes Forum. He is an honorary visiting faculty at the D.Y. Patil Medical Sciences, Navi Mumbai. He was awarded the RSSDI Fellowship for the year 2017 and Fellowship of the Royal College of Physicians of Edinburgh for the year 2019. He is the principal investigator in various global MNC clinical trials, and he has got around 20 papers in national and international journals. And he will be speaking on obesity, diabetes, and COVID-19 and eating. So over to you, Dr. Chawla.
Thank you, Chairperson, sir. Thank you, Dr. Amitabh Biswas and Bengal Diabetes Conference for inviting me. Let me start by sharing the slides. And let me apologize that I'm actually traveling in the car and I have a very, very valid reason for the same. So our alma mater, that is TN Medical College and Nair Hospital, actually celebrates 100 years of its establishment. And there have been great celebrations the whole day. And I was glad to be visiting the alma mater with my batchmates and enjoying that moment. So there was no way I would have given that up. So I'm on the way back, and hopefully there won't be any network issues when we move ahead on this talk. So I'm going to be talking about diabetes, obesity, and I changed the topic a little because it said COVID-19, but I think it's unfortunately, it's COVID-19, 2021, and maybe 22. So I'm going to be speaking about, is there really a link? And that's as specific a topic that I've been given to speak on, the link between diabetes, obesity, and COVID. I'm also, of course, depicting here the multiple waves that we may encounter with COVID. So spread of COVID-19 has reached pandemic proportions, and it represents a threat for increased morbidity and mortality, especially for patients with diabetes, obesity, and hypertension. So when we talk about the diabetes and COVID-19, so I'll speak initially on the link with diabetes and then move on to talk about and show the link with obesity. Epidemiological evidence suggests that diabetes is associated with high risk of infectious disease. People with diabetes are at increased risk for more pneumococcal infection, which is an independent risk factor for developing worse lower respiratory tract infections. Both individuals with type 1 and type 2 diabetes have higher risk for serious infections, 6% of infection-related hospitalization and 12% of infection-related deaths attributed to type 2 diabetes. So in a large observational study, including 1,099 patients with confirmed COVID-19 infection, that indicated that of this 1,099, 173 with severe disease there had existing comorbidities. And when you look at the analysis of which other comorbidities really existed, you see hypertension as prevalent in 23.7% of the population, 16.2 having diabetes, and 5.2 having coronary heart disease. You look at more data coming in from different sections, characteristics, clinical presentation, and outcomes of patients hospitalized with COVID-19. And here we saw the most common comorbidities amongst the data from New York City, 5,700 hospitalized patients. Those having hypertension formed 56% of this population. So hypertension was right up there, followed by obesity at 41.7%, and then diabetes at 33.8%. We also started getting a lot of data on new onset diabetes and the link between COVID and new onset hyperglycemia. So if I look at a review article, a meta-analysis published in November 2020, it showed the COVID-19 infection-related development of diabetes, and we see multiple papers which have shown that, of course, we don't have this established, whether it's a new entity, is it a different entity, is it more temporary, is it stress hyperglycemia, or more specific destruction of the beta cells, which has also been speculated. So COVID-19 infection-related diabetes and mortality, when you look at the numbers, almost 14.4% new onset diabetes in hospitalized patients. Higher rates of ICU admission, even as compared to pre-existing diabetes and those with no diabetes. ICU admission rates, if you compare for those with new diabetes, known diabetics, or those with normal glycemia, you can see 11.7% versus 4.1 versus 1.5. So those with new onset diabetes had the worst outcomes, as we have seen in the past in most cases of stress hyperglycemia having poor outcomes as compared to known diabetics. Now, when we look at the link between COVID-19, the pathogenesis, and diabetes, we need to remember that the entire pathway of the SARS-CoV-2 is through the attachment to the ACE2 enzyme. Now, the ACE2 is presented in individuals with diabetes, and it's present in the lungs, the heart, the kidney, the enterocytes, and of course, the pancreas and the pancreatic beta cells. So we look at this paper, which speaks about the most consistent finding being a tentative causal association between diabetes-related traits and increased ACE2 expression. So based on one of the largest gene studies that they did in individuals with type 2 diabetes, almost we're talking about 898,130 individuals, they found that type 2 diabetes was causally linked to raised ACE2 expression, and that seems to be the strongest pathway. So when we talk about the mechanisms for increased susceptibility to COVID-19 and diabetes, well, this is often a slide that many would have seen. It's a busy slide, but it explains the entry of SARS-CoV-2 into the respiratory tract, infection of the respiratory epithelium, necrosis of the respiratory epithelium leading to pneumonia. You also look at the poor immune response. So in terms of impaired macrophage activity, impaired neutrophil recruitment, impaired interferon alphas productions from the NK cells. So all the pro-inflammatory pathways are exaggerated. The anti-inflammatory pathways get compensated there, leading to increased ACE2 expression, leading to worse infections, the problems with cardiac dysfunction, acute renal injury, and of course the worry of cytokine storm in such individuals. When you further look at the pathways which have been spoken about, well, metabolic syndrome related conditions such as diabetes together with their predisposing conditions can etiologically be linked to COVID-19 pathogens. Then again, we talk about the spike protein with SARS virus getting attached to the ACE2 site, and ACE2 becomes the host for the entry for the virus and then worsening of the infections. There's been emerging information, and when I say emerging, this is something which has emerged over the last year and a half, a lot more papers in the first 6 months of the pandemic. As we move ahead, we talk about the fact that those with diabetes are at increased risk of complications, including death. So fatality rate in patients with diabetes was much higher. We know today, we look at the Indian data also, overall fatality rate would be somewhere around 2.5%. But when you look at the individuals with diabetes, it was high at 7.3. So hyperglycemia predicts mortality. You look at the retrospective cohort from March 1st to April 6th. This is the early days in 2020 in 88 US hospitals. It speaks about COVID-19 patients with diabetes and uncontrolled hyperglycemia had a higher mortality than patients without diabetes or without uncontrolled hyperglycemia. So as high as 28.8% in those with diabetes or hyperglycemia. Those who had normal glycemia or no diabetes, 6.2% there. So hyperglycemia predicts mortality and has 4 times worse outcomes. There seems to be a direct endocrine link, and this is an interesting paper which spoke about the angiotensin and angiotensin 1 to 7, which acts on the MAS receptor pathway, the mitochondrial activator system pathways, which lead to anti-inflammatory and anti-fibrotic response, and that would be favorable to the recovery of patients with COVID. But that doesn't happen. You don't have the ACE moving on to the ACE2 and the ACE 1 to 7 pathways, but rather individuals with severe COVID-19 and diabetes have an imbalance in the activation of these pathways with increased activation of the AT1 receptor and the AT2 receptors. And that increased activation of the AT1 and AT2 receptors is what is responsible for vasoconstriction, inflammation, fibrosis, proliferation, and much worse outcomes in individuals with hypertension, leading to thrombosis, ARDS, and so on. So acute hyperglycemia and mortality have had a strong link. Hyperglycemia and type 2 are independent predictors of mortality and morbidity. If we again summarize these pathways in individuals with hyperglycemia, we're talking about metabolic inflammation. We're talking about possibility of cytokine storm. The fact that patients with diabetes and severe hyperglycemia will have impaired immune response and impaired healing, and the fact that the dysregulated immune response results in aggravated and prolonged lung pathology, and of course, the chances of higher viral loads. So diabetes as a risk factor for COVID-19, this is the statement from the IDF, which spoke about two main reasons for why individuals with diabetes have high risk: functional immunocompromised state associated with diabetes, favorable conditions like hyperglycemia, promoting more viral replication in such individuals. I'm not speaking about the management of diabetes in patients with COVID-19. I think that's a huge topic in itself. But I would bring to forth the fact that the therapeutic aims is to keep the plasma glucose concentration largely between 70 and 180, HbA1c closer to 7. Where required, you would use an FGM or a CGM. The time in range to be tried and kept more than 70% and to avoid hypoglycemia. The principles of glycemic management for COVID-19, good glycemic control is essential. You could tailor the strategies, you could use orals where possible, you may move to using injectables, have the need to use steroids and more insulin. All of that is fine, but at the crux of it is good glycemic control. So management of diabetes with patients with COVID-19 will actually be part of two aspects, whether they are on oral anti-hyperglycemic medications or those on insulin therapy, and then you will have different strategies for the same. What you need to consider for your pharmacological management is the age of the individual, the severity of COVID-19, the presence of cardiovascular comorbidities, and of course, keeping in mind the need to avoid hypoglycemia. Your targets for fasting in mild young patients, it could be aggressive 80 to 110, slightly older of those on steroids 110 to 140, and severe or critically ill 140 to 180 as the targets for fasting. And the postprandial targets are correspondingly listed here, as we can see. So when we look at an overview of the management, well, anti-hyperglycemic agents that can cause volume depletion or hyperglycemia should be avoided. Sglt2 inhibitors have kind of been implicated in the DARE study, and they've been found okay and safe to use, but no real benefits. Dosage of oral anti-diabetic drugs may need to be reduced. If it is necessary to stop metformin, then an alternative treatment needs to be put in place until you can start metformin. You just don't leave the patient alone. Patient on oral diabetes treatment should have their glucose testing done on a regular basis and monitor the sugars. Guidelines for insulin use in such patients: glucose levels more than 180, increase the insulin dose. Testing should be done more frequently, especially if the sugars go beyond 270. You may want to check every 4 hours or advise your patient to do the same. If the blood glucose persists to remain more than 270, you may want to have a look at the urine ketones. And if there is presence of ketones, ask your patient to get in touch with you or any other healthcare provider. I move to the second part of the section quickly, which is talking about the link with obesity and diabetes. Several hundred studies provide evidence that BMI is a strong linear risk factor for severe COVID-19 outcomes, with recent studies suggesting 5 to 10% higher risk for COVID-19 hospitalization for every kilogram per meter increase in the BMI. The genetic data concur with hazard ratios increasing by 14% for every kilogram per meter, every single BMI point. BMI to COVID-19 links differ markedly from prior BMI infection associations and are further supported by multiple biological possible pathways. The excess adiposity appears to be important. Some modifiable risk factors for adverse COVID-19 outcomes are present through this aspect in multiple ethnicities. And it's imperative that medical systems worldwide meet this challenge by upscaling the treatment for prevention of obesity and using treatments where possible. So this is a study which spoke about 334,000 individuals in England during spring of 2020, which showed how increasing BMI was increasing the chances of hospital admission. So for every 10,000 people, those with stage 2 obesity and a BMI more than 35 had the highest chance of hospitalization as compared to those with normal BMI between 18 to 25. So obesity contributes to metabolic derangements, which could be linked to ectopic fat in the liver or pancreas, overall poor vascular health, greater thrombotic potential, and the adverse lung and renal functions in general in people with obesity. There may also be indirect links between obesity and COVID-19, such as an adverse diet-induced microbiome impact on the immune deficiency. So when you look at the potential mechanisms, you could have systemic factors, increased cytokine inflammatory production, a compromised immune system, increased insulin resistance, overall reduced heart function in an individual with obesity, decreased tissue perfusion, and overactivation of the RAS system. Some biomechanical factors which become important: reduce lung compliance, reduce functional residual capacity. So they're already at a higher risk. Increase esophageal and gastric pressures, and increased chances of obstructive sleep apnea and hypoxemia. So all of this is increasing the vulnerability of an individual with obesity to SARS-CoV-2, increased chances of severe course of the COVID-19 infection, and unfortunately, higher mortality rates. And when you look at the current evidence, there is evidence through epidemiological studies. There has been some Mendelian randomization genetic studies, which have again shown the link with obesity. There have been no real great intervention trials, but small studies looking at subsets of patients undergone bariatric surgery who had their BMI reduced by 12 points, found their risk of hospitalization to be 69% lower than those who were continuing to be obese. And then there have been some biological possibilities, as I explained earlier. So obesity and COVID-19, what makes the obese host so vulnerable? You'll appreciate the higher incidence of hazard ratio in those with the higher BMIs. Look at the certain different studies, those with more than 3.35, you're seeing a 7.36 hazard ratio against those with obesity. At studies from Fatality earlier, with more than 40 BMI, you're seeing a hazard ratio of more than 2.45. This seems to be an explanation as to what's going wrong. An obese host, there is chronic inflammation, there is immune system dysfunction, ACE2 receptor overexpression, increased viral entry and increased viral load and spread, more inflammation, insulin and leptin resistance leading to impaired immunity, and severe disease and poor clinical outcome. If I further look more closely into the same pathway, it explains the more pro-inflammatory adipokine presence. The anti-inflammatory adipokines are reduced largely because of the excess fat, which leads to a substantial alteration of the cellular architecture of the adipose tissue. That's responsible for this altered milieu of the inflammation. So elevated fatty acids, reticulum stress, hypoxia, and mitochondrial dysfunction contributes. You have indirect factors as well. You have the locked-in consequences, worse diets, decreased activity. You itself have obesity as a causal risk factor, as explained through multiple pathways. And the fact that obesity very often is linked to comorbid conditions like diabetes, chronic kidney disease, liver disease, and so on. So really the time to upscale prevention to prevent obesity. Now, I found another interesting link between obesity, and I will emphasize only on the impact that we see here. The biological and social factors I've already spoken about, but learnings from these H1N1 studies showed increased viral load, increased shedding time, reduced immunity from infection, decreased vaccine efficacy, and increased chronic disease progression. I must say we have no reports as of now about reduced vaccine efficacy in the obese individuals or those with diabetes, but these were some of the learnings from the previous pandemic. The final point that we need to understand and take home is SARS-CoV-2 causes beta cell damage, possibility of cytokine storm, possibility of admission hyperglycemia or worsening metabolic control in patients with diabetes, or chances of new onset diabetes. All of this in individuals with obesity, worsening inflammation, more pro-coagulatory and pro-thrombotic state, older age, hypertension, and presence of renal disease. You have these as a background, there are chances of much, much poor outcome. So let me conclude by saying type 1 and type 2 diabetes are associated with increased risk of COVID-19 related hospitalization and severe outcomes, including mortality, particularly in people with poor glycemic control. Recent data have suggested an increased risk associated with development of new onset diabetes following COVID-19 hospitalization. However, longer term follow-up data will determine if this kind of diabetes is more permanent. And several hundred studies provide powerful evidence that BMI is a strong linear risk factor for COVID-19 outcomes, with recent studies suggesting 5 to 10% higher risk for COVID-19 hospitalization for every kilogram per meter square increase in BMI. With this, I thank you for inviting me here and hand it back to the chairpersons. Thank you so much.
Thank you very much, Dr. Chawla. You have given a nice presentation. You have given the treatment aspect as well as the mechanisms, how new onset diabetes happens in COVID-19, plus what is the link of obesity and the severity of COVID-19 disease. So since all the three talks are over, now we can go to the question answer session. I don't see any answer questions in the chat box. So I can start with a question to Professor Sahai sir. This question is for Dr. Sahai sir.
Yeah.
Can we have everybody on the
Yeah.
gallery platform there, so we can stop pinning on me and have the gallery and we can have the discussion.
Yes.
Yeah. Sir, you have given a nice presentation. You have said that to do frequent SMBG, like ideal is to do at least 7 times SMBG. So how practically is it possible? Because patients on type 2 diabetes, they are on multiple insulin injection. They fear these pricks. They have to inject insulin, plus they have to prick their fingers for this SMBG. So practically, what would you suggest to the practicing clinicians? Number one. Second, one more thing, sir. Is there any role of frequent SMBG in, say, type 2 diabetes mellitus patient who are on OHAs, poorly controlled? Not only.
So I think what I was trying to show is that highlight in my talk was that even when it is done once a day, it was found to have very good value. It brought down the risk of complications by almost 10% reduction in all the complications, and it was done very cost effectively. I mean, over a period of 10 years, there was a good saving in terms of the money spent on SMBG being also calculated and all that. So there is a great benefit of doing SMBG even in patients with type 2 diabetes who are not on insulin. On insulin, definitely it is valuable. I mean, all the guidelines, even the ESI RSSDI guideline is recommending doing it on the minimum once a day in insulin treated patients. While in non-insulin treated patients also, you see the benefits in terms of providing feedback on the dietary habits, on the exercise patterns. So it helps in several ways, and in deciding therapy, changes in therapy. So it helps in several ways, and intensified monitoring, as doing it about 3-4 times in a day or even 7 times in a day, is recommended in some situations, like in managing patients with gestational diabetes, managing patients with type 1 diabetes, where there are significant fluctuations in the glucose levels. In such situations, it may be required more frequently, but otherwise, even once in a day is a very practical approach, and it can be useful even in patients who are not on insulin.
Thank you, sir.
May I give one comment?
Yeah.
Yes, sir.
Yeah. So I think Rakesh very rightly pointed out that even you do one single value of a glucose in patients with type 2 diabetes who are even on OHAs is helpful. Now, what it means? It means that the patient is induced to involve in his own care. So even by doing a single value, patients become more vigilant because they know that what is the output. So they can modify their lifestyle or they can modify their medications. What I do in clinical that I would like to share with you is that those who are on oral hypoglycemic agents, we usually recommend to them to ask to do the blood glucose post-prandial. So 2 hours post-prandial, suppose it comes high in more than 200. Then either they do some exercise or they reduce their diet or calorie intake for the next week. While those are insulin, you should preferably do a pre-meal so you can modify the doses accordingly. So I think you can ask even the person which type of blood glucose values they want and how can you modify. Even you do a single value, even in patients with OHS.
And doing a pattern value, that is doing at different times of the day. If you're doing post-meal, do different post-meals. That is, one day you do it after breakfast, another day you do it after lunch, another day you do it after dinner.
That will fairly give an idea of a 24-hour glucose profile if you do like a 3 post-meal values, but you modify accordingly.
Thank you, sir.
Dipal sir, can I ask a question?
Yeah, Dr. Amar, please go ahead.
Yes.
Go ahead,
I thank all the speakers for the wonderful deliberation. It's always a delight to listen to them. Is Dr. Deep Doctor here?
Yes.
Yeah, he is there.
I'm here.
Deepta, thank you. It was a very nice and lucid presentation. I have just 2 queries. One, you have very nicely highlighted the mixed meal. It's a very easily available and cheap mixed meal which you the study which you have shown with Good Day Biscuit and the Amul Lychee milk. I think that is a very practical way of testing the mixed milk. Now, we have a lot of health drinks available in the market. I mean, like the Ensure and the Prohance D. These are some of the brand names to mention, if I can mention them. So, do you think there is any utility or any, like, you can use these as a substitute for the mixed meal test if you can advise the patient?
Let me start first of all paying my regards to all the teachers here on Teachers Day. We have teachers here, Bhansali sir here. My regards to you, sir. Coming to the question, I think nothing prevents us. We are flexible about it. You can use any branded protein supplements or health supplements. The idea is to replicate a meal around 400 to maybe 450 kilocalories per day with a good representation around 40 to 50% carbs, around maybe 30% of proteins and 20% of fats. The advantage of using any of the proprietary meal supplements, they have a food label available there. You can read it, you can do the calculation. So whatever you are comfortable at your center or OPD, you can standardize it and use it in your practice. There's no fix that you have to use Sastacal or you have to use Gatorade or anything. It's not, it doesn't work like that. Yeah.
Okay, if I can ask a question to Dr. Deep Datta, I just wanted to ask him. He started off his talk with a very interesting observation that C-peptide has got several roles to play in kidney disease and several other issues in terms of heart failure regulation and all that. So, but we don't have any therapeutic role identified as yet. So what I was trying to ask him is that do you look at a difference in terms of, in a patient who is receiving insulin therapy versus somebody who is receiving a GLP-1 therapy? A GLP-1 therapy probably theoretically can increase the C-peptide levels also. Could it have additional benefits as compared to somebody who's on insulin versus GLP-1 in a patient with say type 2 diabetes?
Sir, as expected, you always ask the toughest questions. I don't have a clear answer for this. A great question, sir. I think I have to go back and read about it. But as you said, GLP-1's lot of pleiotropic benefits we have seen. We know that it is a superior agent in terms of improving cardiovascular outcomes. Maybe it is one of the mechanisms by which it exerts its benefits. The full answer I don't have to a question, sir.
If Dr. Bhansali sir has some comments on this.
Yeah, I would like to answer. I think question is very pertinent and very rightly asked. Theoretically, yes, because the GLP-1 will definitely increase C-peptide and insulin, while versus exogenous insulin. But let us see that what is the contribution of the C-peptide in facilitating these actions on the heart. Or only I think where most of the studies are available, that is for a diabetic neuropathy, where the C-peptide have been shown to be effective. But otherwise, for the rest of the illnesses, rest of the concurrent comorbidities, I think the role is only plausible. So I just say that the contribution or the effect size of the C-peptide on different organ functions is still remains to be elucidated.
Thank you, sir. One last question to Deepta again. So, is there any cutoff would you suggest to in the post-mixed meal C-peptide level? Is there any cutoff you suggest where you would consider that OHS will still be effective in the management of type 2 diabetes patients? Because when we are thinking of changing to insulin, the patients are still not convinced to start off insulin. We are still on continuing OHS with 3-4 OHS. So if we to see whether the adequacy of the insulin reserve, is there any cutoff you'd suggest that beyond which we can safely and reliably continue OADs in these patients?
Well, the answer to it is that we need to develop ethnicity-based, cohort-based, population-based cutoffs. The C-peptide assay is interfered by so many variables: the underlying insulin resistance, underlying the glucotoxicity, the degree of glycemic control. So it would be fallacious to expect an upper cutoff. But we have data to show that if you have done a stimulated 1 hour post-meal C-peptide, and if the value comes less than 0.6 nanograms per ml, it is reasonable to assume that patient virtually has minimal to no clinically significant beta cell function. There is no point of beating such pancreas with more OADs. Going for insulin therapy is the safest and the best way to manage diabetes in them.
I think just deep. Sorry to interrupt you here.
Yes, sir.
One comment is even unstimulated, even if you do a fasting C-peptide, if it is less than 0.6 nanogram per ml, it is very likely to be either a severe insulin deficiency or maybe a LADA or maybe type 1 diabetes. If it is a more than fasting C-peptide is more than 1.2 nanogram per ml, likely to have a reasonably good result and may respond to OHA. If you do a stimulated C-peptide, glucagon is less preferable than the mixed meal. The mixed meal is a more comprehensive than the glucagon. And they say the cutoff usually seen in various wide population, that is around more than 3 nanogram per ml. If it is there, then it is likely to be very, very significant that they may continue to respond to oral hypoglycemic agents. But you see that it all depends on what assay you use, one, and secondly, the lot of variability, not because of ethnicity, but what BMI you have. So that's another major important factor of deciding the level of C-peptide.
Thank you, sir.
Ask a quick question,
Okay.
organizers. I'll just take half a minute, and this is to Deep and to Dr. Bansali. So we're speaking about C-peptide. Is there any role of doing this evaluation while on the treatment, or we're talking only at the beginning for diagnostic purpose? Is there a role, say 5 years, 10 years down diabetes, again trying to evaluate C-peptide for somebody who's already been on OHA for a while?
It can be done anytime. It's important to keep in mind before ordering the test, why are we doing the test? What are we trying to achieve by doing the test? So it depends. If a patient who is not convinced to just start insulin, it's a great way to convince the patient. So some concrete data, see your beta cell reserve is virtually not working. It's time you go on insulin, right? I just showed a paper in my presentation. There are studies to show that in post-metabolic surgery, if the C-peptide levels are more than 3 nanograms per ml, Bhansali has quoted the same value, they have a very high role in going to diabetes remission. So now we talk of diabetes remission for these people. So if you want to see your patients who are likely to go into remission, I think people who have a very robust C-peptide value, if they go for a good therapeutic diet and lifestyle change and weight loss, we can try to achieve that. So it can be done any point of the duration of diabetes. It's important to know before ordering the test, what are we trying to look for?
Fair. Thank you.
I have a quick question to Dr. Manoj Chawla. So you said that around 18-20% of patients in COVID-19 have new onset diabetes. So in those patients, even if the hyperglycemia is not very severe, do you start with insulin or OHS in new onset diabetes? Yeah.
So again, the new onset diabetes, the treatment choice completely depends on patient's severity of the infection. So if the patient doesn't have severe form of COVID, is still having, is being treated at home, is orally able to ingest, you may very well use any of the oral drugs which are warranted and which have been proven to be safe to use. Your choice or need to use insulin would only depend if there is severe infection or you're using steroids or this patient is in a critical situation, then of course your natural choice is going to be insulin. So the choice of therapy is going to be dependent on the other factors that I just mentioned, and not just the fact that somebody has new onset hyperglycemia post-COVID.
I think one comment I would like to make. Hello, may I make one comment?
Yes, sir.
Yes, sir.
Yeah. So I think Manoj rightly pointed out that it all depends on severity of disease. But I think the one OHA which is the most preferred in COVID-19 is DPP-4 inhibitors.
DPP-4.
Yeah, the DPP-4 has got an additional role of preventing the entry of the virus into the lung, because the DPP-4 receptor is also present into the lung epithelium. So the DPP-4, this entry of the COVID-19 can also be prevented by that. That's why if you see the recommendations, even in patients, those who are severely ill, even DPP-4 can be continued. Metformin, it all depends on severity. If they have mild disease, then you can continue your metformin and you can continue DPP-4 inhibitor. But if they are having a severe disease, best is you resort to insulin. But only the safest drug or the beneficial drug, in fact, is DPP-4 inhibitors.
Thank you, sir. So if there are no more questions, I think we can conclude this session. I thank all the speakers and all the participants for this lively discussion. And with this, I think we can conclude this session.
Thank you. Thank you for having us.
Thank you.
Thank you. Again, I am just thank you, speaker, for the last. Now we will move to our next session, that is an audition. For that, I will invite Dr. Amitabh Vishwas, Organizing Secretary for Bdcon, and Dr. Shomik Now for the Scientific Chairperson for Bdcon to conduct the next prestigious audition session. Over to you, sir. Prestigious audition session. Over to you, sir.
Good evening. Good evening, sir. Good evening, everybody.
Good
My
evening,
humble
good
pranam
evening,
again
sir.
to all the teachers for the great deliveries. Pranam, sir. Sir, pranam.
Pranam, sir, pranam.
The APJ Abdul Kalam Mauritian is our homage to Bharat APJ Abdul Kalam, the inspiring Indian aerospace scientist who ignited numerous minds and also served as the 11th President of India. Bengal Diabetes Foundation is privileged and proud to confer the APJ Abdul Kalam Mauritian for 2021. Sir, it was supposed to be given by Professor Dr. R.G. Das. Unfortunately, he left for heavenly abode on this 21st of August. Professor Dash is an endocrinologist par excellence who has trained numerous students across India in the art and science of endocrinology. Professor R.G. Dash is a towering figure and a pioneer in Indian endocrinology and is the teacher of the teachers in this discipline. I offer my humble pranam to his faith and pray the Almighty for the soul to rest in peace. On this, I request everybody to observe 1 minute silence for this. It's over. Proceed for the next proceedings.
Thank you. Thank you. And as we have discussed soon, just a short while ago, we are extremely mournful to announce the demise of our respected Professor R.J. Dash. However, we are very proud and privileged to have his very deserving student, very meritorious student who has agreed to take up the mantle of his teacher, Professor Anil Bhansali. Professor Bhansali needs no introduction to any endocrinologist or diabetologist in India. Without wasting further time, I would request Professor Anil Bhansali to take up the mantle of his guru and proceed with this year's APJ Abdul Kalam Mauritian.
Thank you. Thank you, Somik. Thank you for a very, very kind introduction. And it was a very saddening and shocking when we had a news of demise of Professor R.J. Dash. And he was a great teacher. He was a mentor for me. And I had an opportunity to stay with him for 17 years. So I had a very long inning with him. I think none of our fraternity had so much of long inning with him. Very wonderful experience I had. It is very difficult to find a teacher of that caliber. He was a teacher par excellence. He was a great analyst, and he was the first DM in endocrinology in the country. And he was, in fact, so many students he has mentored in the country. So everywhere, not only in the country but globally, you will find his students, and there is always his legacy will live on. And thank you, Dr. Amitabh, for giving me this opportunity. Though this is painful to say that I'm delivering on behalf of Professor R.J. Dash, because losing him is a great worry in my mind and heart. But still, the time is not in our hands. So I will be delivering this oration on his behalf, and I deeply remember him and I deeply cherish his memories. So with this, I will share my slides. Visible now?
No, no, not yet.
Slides are visible?
No, no.
No, sir.
No, okay.
Now it is coming.
Visible now, sir?
Yes.
Yeah. Okay, sir?
Yes, sir.
Yeah. Moving now. Slides are moving, sir?
Yes, sir. They are moving.
Hello?
They're clear.
Yeah, fine. So I will start. So my topic is for today's oration is errors in management of type 2 diabetes. And why did I choose this topic? Mainly because this is just as a comprehensive management of diabetes for a physicians that can surmise them how to use this information in clinical practice. That's one. And secondly, remember, I have no intention to find any fault among the physicians in their clinical exercise, what they are doing, but it is just to surmise them is that what are the errors which we usually make in clinical practice and which can be easily avoided. So let us start with that. What are the things which one physician should know in a diagnosis of a disease? So first, I think that we should know what is a normal glucose profile. So where the fasting plasma glucose is less than 100, 2-hour post glucose. It is not 2 hours post meal, which we usually talk, less than 140. If you do a random, it should be less than 140, and hemoglobin A1C should be less than 5.7. So this is considered as a normal glucose profile, which a physician should know. Diagnostic criteria for diabetes, we all know that fasting is more than 126 2-hour PGs, again 75 gram more than 200, random more than 200 with symptoms. So you will see that the random is always accompanied with symptoms. Otherwise, your fasting or 2-hour PG may be absolutely symptom free. Hemoglobin A1C more than 6.5 should be confirmed on subsequent day unless patient is having a severe hyperglycemia or DKA. The diagnostic criteria remains same or similar. Those who have got asymptomatic, those who are asymptomatic, and you have got the same 2 values for diagnosis, but you do preferably 1 value fasting plasma glucose and random in presence of symptoms. Fasting plasma glucose is preferred to reconfirm the diabetes in asymptomatic subjects because the fasting plasma glucose is usually consistent and the most reproducible. That's why rather than doing a random plasma glucose value, do a fasting plasma glucose values for making a diagnosis. Fasting sample should be taken after an overnight fast of 8 hours to 14 hours. The postprandial values are like 2-hour values which you do in clinical practice for monitoring of a disease are not made for diagnosis. So either they should be considered as a random plasma glucose, but they're for monitoring, they are considered as a postprandial glucose. The pre-diabetes, we are all aware about IFG and IGT, fasting plasma glucose between 100 to 125, and impaired fasting glucose between 140 to 199, and corroborated with hemoglobin A1C between 5.7 to 6.4%. And I think the both impaired fasting as well as impaired glucose tolerance tests have got a similar connotation for progression to type 2 diabetes. Roughly around 3 to 4% of the individuals, they they progress to the diabetes. Physicians should also know that the sample which are obtaining from the patients to assess the blood glucose, whether it is a venous plasma or whole venous blood. The venous plasma values are 10 to 15% higher than the whole venous blood. And remember, whatever the values which I mentioned as 126 and 200, they are on whole venous plasma values. So remember that because if you take a whole venous blood, the values are lower, mainly because the RBC consumes some amount of glucose, and partly the volume of the sample is also attributed by the RBCs. Capillary glucose is not, even though we know that the glucometers now are calibrated to the plasma glucose, but still it is not recommended for diagnosis. However, it is useful for monitoring. Urine sugar is not useful neither in diagnosis nor in monitoring. A word about a hemoglobin A1C and diagnosis of type 2 diabetes. We know about pre-diabetes and diabetes. The levels are 5.7 to 6.4 and more than 6.5 respectively. But remember, this cutoff of 6.5% has got a very high specificity but low sensitivity. And it is not useful in type 1 and hemoglobinopathies. So if you see that this is data we published in JSCM in 2010, and this was the newly diagnosed based on a 2,271 individuals in a community survey at a hemoglobin A1C of 6.5%, the sensitivity was 65, means the 35% of patients were still missed, while the specificity was low. So those who have got already hemoglobin A1C of more than 6.5, the probability of them being diabetic is around 18%. If you go further, the GTT, the certain precautions has to be observed before we perform the GTT. Overnight fast means after 10, nothing is to be taken. The diet must contain at least 150 gram carb for 3 days, no alcohol in preceding night, no bad tea in the morning, no exercise. Many people, they do a morning walk and then you go for the glucose values in GTT and use 75 gram and hydrous glucose rather than monohydrous, which is available even in most of the part of the country. Then your weight becomes 82.5 gram, and only 2 samples are to be taken at 0 and 2 hours rather than practice of 3, 1, 2, 3, or some people take even at every 30 minutes. So only recommendation is for 2 samples. If you do a GTT during pregnancy, the mostly one in Mahan criteria, if you follow, you require 4 samples and dose is 100 gram glucose. If you follow the IA DPC SG criteria, you require 75 gram glucose and only 3 samples, and the cutoffs are 92, 180, and 150. So I think these are to be remembered by a physician. So that can be the minor errors in making a diagnosis can be avoided. Many times you find a dubious values and you are not able to make a diagnosis correct. Suppose your fasting plasma glucose comes as 115 and random is more than 200. So your random qualifies, but your fasting does not qualify. Also, or vice versa, your fasting is 130 and RPG is 180. So your fasting now qualifies and random does not qualify. Or you do a fasting and hemoglobin A1C. The hemoglobin A1C qualifies with the fasting. So the dictum in this scenario is that the value which is abnormal is to be repeated in subsequent. So you repeat the value, like fasting is 115 and the RPG is 200, so repeat RPG again. So this may be confirming the diagnosis. Hyperglycemia during acute MI and stress, it should be in a hospital setting, the blood glucose value of 140 milligram per deciliter in inpatient setting, and you revise the diagnosis, but the HbA1c will be less than 6.5, and revise the diagnosis once the stress is over. Do not use the word like terms like mild diabetes or severe diabetes, because this unnecessarily will appease the patients and patients will be taking it very lightly or very seriously. The best is diabetes is diabetes. A word about the type of diabetes. We all know DDM and NIDM, they are old terms and we back changed in 1997. But I think I will highlight on 2 entities which is now easily recognized and very commonly recognized now is LADA and Flatbush. A word about the LADA, that is a latent autoimmune diabetes of adults. Age of onset is usually more than 30, quite symptomatic, sarcopenic. They don't have features of insulin resistance, glucose values are high, ketone may be absent initially or may be present. Usually no family history of diabetes. They may respond to OHA, it worsens the disease process, but they get positive, and CPAP is usually less than 0.6. So this is a subset of the patients who are to be identified, and unnecessarily continuation of the oral hypoglycemic agents is to be abandoned. Because unnecessarily continuing the OHAs in these patients will further exacerbate the autoimmune process. The another entity is called as a Flatbush, that is again commonly recognized in our clinical practice. You have a young age of onset of disease, they are obese, they are insulin resistant, usually presents as decay to begin with. The beta cell function usually recovers after intensive insulin treatment, later may respond to OADs, and they are Z65 negative. So this is some subset of patients who later on responds to OHA as opposed to LADA, but they have to be identified, they are obese and they are insulin resistant. Why they are coming with a decay to begin with? Possibly it's a very severe insight at the onset of the disease. That's why it's a beta cell stunning. So hardly any insulin production and they won't decay. Let us see what are the common errors which you make in clinical examination. The height and weight are usually not taken. The BMI, calorie calculations, choice of therapy, I think they are all determined by your height and weight. So height and weight has to be taken at a first initial baseline examination. The features of insulin resistance should be looked for: acanthosis, skin tags, double chin, central obesity. The waistline has to be measured to define, because most of the Indians are still They are centrally obese, but they are not obese and it correlates with insulin resistance. The peripheral pulses are usually not palpated. If you look for a carotid bruit, it is a surrogate marker of CAD. Absent posterior tibial or dorsalis pedis, it is a marker of PVD. If you find a renal bruit, it's a marker of a renal arteriostosis, and you have to be cautious for the use of ACE and ARBs. So I think there are certain clinical examinations which you should look for. You should look for foot, usually ignored, callosities, nail, pulses, and arch. And in one of the studies, we showed around 8% of the people with diabetic foot ulcer died of foot sepsis. So it's one of the important causes of mortality now with the increasing longevity in patients with type 2 diabetes. The hand is to be examined, the Dupuytren contracture, limited joint mobility, trigger finger. I think all you should look for these issues. And the fundus, the most common cause of painless loss of vision, to be seen initially by a physician and later on by the ophthalmologist with diabetic people. So I think these are the certain things which has to be looked for by a physician in a given patient. The next error which we usually make is or mainly focus on glucose and hemoglobin. I think we should also focus now on glycemic variability because that is a very important. And so now the control of diabetes is from glucocentric to a holistic approach where you have a comprehensive control of diabetes from fasting, PP, hemoglobin A1C, and we should top time in range more than 70%. Blood pressure, LDL, non-HDL should also be focused because the residual risk remains. Even your LDL become less than 70, urinary albumin should be less than 30, and weight should try to achieve or target the weight 5 to 10% from baseline or ideal. So what I mean to say is that the focus should drift away from the glucocentric approach to the comprehensive approach. Then another question which is usually missed in clinical practice is who should be on diet control? They're usually not identified but to be individualized. Young diabetes without comorbidity, GDM, post-renal transplant, and acute amyloid stroke. These are at least 4 or 5 subsets of it. Ideally, everyone should be, but this has to be individualized, and these are some subsets of patients who really require a very tight control of diabetes. Then it may be very, very rewarding for their outcomes. In a treatment strategies, the common errors which you make is the lifestyle modification. You should always decide and aim the patient to lose at least 5% of the weight loss if they are obese. But this should be advised after evaluation for dyspnea on exertion, obvious foot disease, and diabetes. So we usually advise go for a lifestyle modification program, but I think we should do these prior workup before we go for or before we resort to the lifestyle modification program. The 4 kilometer in 40 minutes, 5 days a week standard that we always talk, but the current trend for a 10,000 steps a day, we don't have a robust data for it, but I think that still makes a good sense, and that involves the patients in their own physical program. And if you walk at 10,000 steps a day, you approximately walk around 6 kilometers a day. That's a reasonably good exercise. If your aim is to lose weight, the exercise should be a stretch. Because if you do an intermittent exercise for 10 minutes or 15 minutes, you lose mainly carbohydrates. But if you really want to burn the fat, then the duration of exercise at a given point of time should stretch more than 30 minutes. Then and then you start burning fat. So both isometric and isotonic exercises should be performed. That should also be stressed. That if you do not only the regular walk or brisk walk, but you also do some isometric exercises in form of weight bearing, that is also good. So a combination of exercise is better than the monotonous exercise of brisk walk. Audible, sir? Hello? Hello?
Hello, hello, yes, please.
Audible, sir?
Yeah, very well.
Audible, sir.
So now the thing which has changed and which the physician should approach is from inertia to proactive. We always have seen this slide that OHA, 1 OHA, 2 OHA, now you have 5 or 6 OHAs in your hand. And the semaglutide is also coming to this later in this country. So you have 7 OHAs in your hand and you always have a appeasing to the patients and delaying the insulin. So I think most of the guidelines, they prefer sequential than combination. That's still safe. So use one drug and then it fails and two drugs. But I think the whole scenario is now changing. And there are some guidelines like ACE now they do recommend even initial start with the two drugs to begin with. If your baseline hemoglobin A1C is more than 9, and even the current guideline, even the baseline hemoglobin A1C is more than 7.5, the ACE says that you can start with the two drugs, particularly DPP4 and Metformin. And this was endorsed by the verified trial. The failure with one drug within 3 months of optimal treatment require addition of next line therapy. So you got only time frame of 3 months for one drug, even you go by the sequential regimen. There should be no hesitancy to aid insulin if your baseline hemoglobin A1C is more than 10, and by the ACE guideline if it is more than 9, on failure with optimal dosage of 2 OADs. So the patient is already on 3 OADs, the best is you add basal insulin. Metformin is a first line drug. I think should not be debated except that we don't have a CVOT trial as we have with all your Sglt2 inhibitors and GLP-1 analogs. But I think metformin has got a very robust data from UKPDS and it has got many advantages: weight neutral, minimal hypos, cardioprotective, inexpensive, and effective reduction in hemoglobin A1C by 1.5%. I think metformin continues to stay as a first line drug or first in a first year, as I think many drugs in future, possibly the SEMA and possibly the SGLT2, they're competing to stand in a first year. But I think the metformin still remains as a first line drug, despite we don't have a robust CVOT trial with metformin. So this is now the guideline saying the whole guideline is now totally based on your presence of or absence of ASCVD, heart failure, or CKD. If you have got a heart failure, the choice is SGLT2. If you have got a ASCVD, again the choice is SGLT2, unless contraindicated, then GLP-1. And if the choice is in the CKD, then again the choice is SGLT2. So I think the SGLT2 figures out very prominently if there is a concurrent ASCVD. If there is no ASCVD, then you have got a plethora of drugs, whether you use a sulfonylurea, whether you use a DPP4, whether you use a pioglitazone. You can use whatever you want, but I think our aim is not to go from inertia to very proactive approach. Every 3 months, monitor hemoglobin A1C. Try to achieve less than 7. If you're not able to achieve, add 1 or 2 or 3. And once you reach the 3 drugs maximally, then best is you shift to the or you add to the basal insulin. This should be the guideline after second line drug. If there is an ASCVD, you give an SGLT2 or GLP-1. If there is a CCF SGLT2, if there is a CVA, and pioglitazone has got some robust data on this. If the CKD SGLT2 EGFR is more than 30, and you add DPP4 and linagliptin, the EGFR is less than. So I think this is some guideline you can add as a second line drug. A word about the sequential therapy versus combination therapy, because some guidelines ACE recommend sequential therapy, combination therapy, while AD and ESD still continues to recommend the sequential therapy. So combination therapy to begin with will be more effective in sustained glycemic control, reduced glycemic variability, early achievement of hemoglobin A1C targets, and the evidence by the verified trial. We are the part of this trial, and we have over 22 patients from our center, and that showed very clearly if you give a metformin plus vildagliptin together, then the achieving the target hemoglobin A1C and is higher, and secondly, patients with an event is much lower, those who are in combination as opposed to those who are only on metformin. So means this reduces the risk for the events even because you are able to sustain with almost euglycemia when you start with metformin plus vildagliptin and the combination therapy. A commonly asked question about the time of administration of drugs. So this I have just summarized for the convenience of the audience. A metformin should be given preferably before meal, because the metformin also increases the GLP-1 secretion and also increases GLP-1 receptor expression in beta cells. So if you give it prior to meal, it will be possibly better. If it is not tolerated, then with meal or after meal. SGLT2 preferably given in the morning, so some diuresis can take place in the morning. Sulfonylurea 30 minutes prior to meal, DPP4 30 minutes prior to meal, a carbo just before major meal, Bdcon preferably before meals because they also contain, but give a fixed time. Regular insulin 30 minutes prior to meal, short-acting analogs 5 minutes before meal, and long-acting a fixed day of the time. So I think this is one of the time of administration is the most because Mostly the patient asks at what time I should take this medication. So we should be very precise in relation to time and meal. When to add insulin, I think everyone may have a debate on this issue and you can go on to debate, but I think I'll just summarize for that. Patients with type 2 diabetes presenting as emergency admission, AMI, sepsis, CVA, DKA, no choice, give insulin. Fasting sugar is more than 250, random is more than 300, hemoglobin A1C is more than 10, give insulin. Failure to achieve target hemoglobin A1C with optimal dose of 3 OLDs, which will include metformin, sulfonylurea or DPP4, Sglt2 or Pioglitazone. So out of these, any 6 drugs or a combination of 3 or further addition of OLD does not help in achieving that. That's important, I think one has to understand. So if you make a 4 OLDs or 5 OLDs, it will not help in achieving the target unless you add insulin. Gestational diabetes mellitus, the best answer is insulin. And long-acting analogs versus premix insulin, there will be again debate what you should add insulin. I think if the fasting hyperglycemia is an issue, then give a long-acting. If both fasting and postprandial, you can use a premix insulin. Even a single injection will be good enough. A word about errors in monitoring. So normally the fasting sugar is regularly done by most of the patients because the glucometers are now available. But the PPG, they do at a very different time, sometime at 1 hour, sometime at 1.5 hours. Hemoglobin A1C is not easily available even at the point of care services. The blood pressure is occasionally monitored even by the physicians, they don't monitor. Fundus occasionally and foot examination is usually not done. So these are the guidelines which is recommended by the ADA ESG. So the fasting and PP intensive control that you do for a 4 to 7 point profile. If it is a conventional control, you can do monitor at least 1 or 2 reading in a week, followed by once stable, then you do fortnightly. Hemoglobin A1C once in 3 months, lipids once in a year. If the target not achieved, then 3 monthly, micronuria once a year, fundus once a year, and foot examination once a year. A word about lipids and diabetes. The targets are now 30 to 50% reduction from baseline LDL. The previous targets of cutoff for absolute cutoff of 100 milligram per deciliter of LDL or 70 milligram per deciliter of LDL, I think, have been eliminated. And this is mainly because some of the patients with acute coronary events are also found to have a LDL cholesterol of less than 100. So then they will be deprived of giving the statins. So the best is that now it's not the absolute cutoff, it's a delta change in LDL cholesterol now we recommend. So we require a 30 to 50% reduction from baseline LDL. Age is any diabetic between the age group of 40 to 75 years. If they have already established ASCVD, they should be on high intensity. If they are not having an ASCVD but having a cardiovascular, at least one cardiovascular spectrum, they should be on moderate intensity spectrum. So I think it is very difficult to find a diabetic without a single cardiovascular. Either they will be hypertensive, they will be having a dyslipidemia, or they will be having a hypertension, or they will be having migraine. So by this, I think every patient of diabetes in the age group of 40 to 75 years, even without ASCVD, but maybe harboring a one CV risk factors, they will be on statins. For the age group of 20 to 39 years, if they have a diabetes with risk factors, then statin therapy can be considered. We don't have a data for that. But for 40 to 75, we have a data. Our target is very defined. For ASCVD, high intensity. So without ASCVD, moderate intensity. The time of administration, add ezetimibe or PCSK9 inhibitors, the diabetes with ASCVD with LDL more than 7, particularly in those who already has got an ASCVD. Time of administration preferably at bedtime because the HMG coenzyme reductive activity is peak at bedtime. The TG is usually not targeted. For triglycerides, the residual risk always remains even if you normalize LDL. Then I think the best is if someone has got a TG of more than 135 in a range group of 135 to 499, LDL is already normalized and they have got some cardiovascular risk, then the TG should also be targeted. A word about hypertension and diabetes. The BP is usually not monitored. So BP should be taken not only in sitting position but look for postural drop. And I think preferably measure at each visit after 15 minutes of rest. We should define the targets 140 by 90 by JNC 8. But those who have diabetic kidney disease, 130 by 80 is the target for that. And this is the summary of all antihypertensives which we like to use in diabetics. The control of BP in type 2 diabetes is polytherapy required. It's a state of resistant hypertension. Like a pheochromocytoma, Cushing's, we have a resistant hypertension. Diabetes is also a state of resistant hypertension. So they require usually 2 to 3 drugs or sometimes even 4 antihypertensives for the control of the disease. Hypertensive normothermics, ACE-ARBs, normotensive microneurics, ACE-ARBs, hypertensive microneurics, ACE-ARB, and Sglt2, I would like to add to that. Macroproteinurics, ACE-ARB, and Sglt2. Start with 2 drugs if initial BP is 160/100. If BP is uncontrolled, don't hesitate to add CCBs, hydrochlorothiazide if there is systolic hypertension, and alpha blockers. If there is CAD, do not hesitate to use beta blockers in fear of hypoglycemia. Add because the beta blockers are the useful drugs to prevent the sudden death in patients with already established ASCVD. So to conclude this oration, the management of diabetes is a state of art and it has to be individualized. The diagnosis should be confidently acknowledged. The clinical examination should be perfect. The choice of therapy is tailor-made. Now, it is not that every head does not fit with every head. So you have to give a different head to the different people. Associated comorbidity should be effectively treated. I think there is all if you take care and the physician is aware about that, the management of diabetes will improve and that will translate into the better longevity of these patients. Thank you. Thank you for your patience here.
Sir, thank you very much for the orations. As there is no question and answers, we proceed to the next sessions.
Good evening. Now we'll proceed to session 2. For this session, we'll invite Dr. Shamol Kundu, one of the senior teacher in medical education system and senior medicine professor in the Department of General Medicine in Makura Samilani Medical College and Hospital, Makura. We welcome you, sir. We also welcome Dr. Suneshra Mondo, one of the young endocrinologists here. She is an erudite scholar and see her achievement in the school. She has won the ESI Rajiv Gandhi Award for the best research pair in 2020. And we also invite Dr. Saptarjit Roy, who is the Department of Medicine in Central Hospital, ECM. With this, over to Chairperson to conduct the next session, please.
Hello.
Am I audible?
Yeah.
Good evening, everybody. I'm Professor Shamol Kundu. I thank the organizers for inviting me in such a very august gathering. We were waiting for the last 1 year. It's customary to introduce Professor Cardinal Surender Kumar. He is the first speaker in this session. Professor Kumar is an eminent endocrinologist of India, and he is the honorary endocrinologist of President of India. He did his DM endocrinology from All India Institute of Medical Sciences, and he is holding he did his fellowship in International Academy of Medical Science. He is holding the post of President of SARC Diabetes Association, and he's the chairman in the Department of Endocrinology and Metabolism, Sargangaram Hospital. The topic is very interesting. I won't go to the discussion. We will listen from the eminent speaker. He will describe on the interpretation of thyroid function test. let me call Dr. Surender Kumar sir. Please take on the stage.
Thank you so much, sir. Thank you for the kind words. Now let me, is my slides visible? Is it visible?
No, sir.
No, sir.
You have to send me that share screen. Where is it? Yeah. Yes. Now it's visible?
Yeah.
Right. And audible also?
Yes, you are audible.
Right. Good evening, friends. I'll be talking about interpreting abnormal thyroid function tests. There was a time when the clinical medicine was more important, and these days laboratory medicine is taking over. Patients get 300 tests, 400 tests done, and then they search what disease I got. Now that's truly speaking, not a clinical medicine. We should look for the clinical examination first and come to a clinical diagnosis and then ask for the investigations. That is the right way, but somehow due to it has got executive checkup has got its own advantages as well as disadvantages, but somehow I'll be talking about how to interpret the abnormal test. Now, firstly, about the thyroid gland. It's extremely important that we must make a clinical diagnosis that what are we looking for. For a thyroid patient may have local symptoms like pain in the throat, fever, difficulty in swallowing, or may have no local symptoms at all and have systemic symptoms suggestive of thyrotoxicosis or hyperthyroidism or hypothyroidism. So accordingly, one has to plan for the investigation. Now, the common diseases are hypothyroidism, which may be goitrous, non-goitrous, congenital hypothyroidism or central hypothyroidism, or sometimes thyrotoxicosis, which may be either in the form of thyroiditis, which is pretty common, or hyperthyroidism, because the treatment in both is completely different. So correct diagnosis is important. And the third is only thyroid gland is enlarged. Now, just a bit about the thyroid. This thyroid follicle is a completely independent functional unit. This is that follicular cell. It takes help of iodine from the general circulation and converts tyrosine to monoiodotyrosine, diiodotyrosine, tri, and then tetra, which is the T4. And then it throws out into the common pool, and as and when required, they are picked up by the parafollicular cells, and then they are put into the general circulation, where T4 and T3, from T4 to T3 it gets converted. Now, it's equally important to understand the hormone transport. The carriers of the thyroid hormones, 99% of the circulating T4 and T3 is bound to the plasma protein, and 75% is bound to thyroxine binding globulin, and around 15% is thyroxine binding prealbumin. Next is around 7%, and then small quantity to HDL also. Now, it's only the free form of thyroid hormones which is effective. Rest is stored as a storehouse. So if the unbound free hormone is metabolically active, but sometimes the total T3, T4 values may be high or low depending upon the binding of the proteins. So total serum T3 and T4, if the TBG is on the higher side, the total T3, T4 is going to be on the higher side, but functionally active, metabolically active, free T3 and free T4 concentration remains unchanged. And similarly, if TBG is low, the total T4, T3 may be decreased, but free T3, T4, they will remain normal. It's also important to have a small view that certain drugs, they make the changes in the thyroid function, and thus not in the function, but in the thyroid hormone values. Androgens, if they are on the higher side, they leads to low serum binding globulin. And similarly, if estrogen levels are on the higher side, like in pregnancy or other medication, etc., then the total thyroid hormones may be on the higher side, but free hormone values are normal. Decrease in the T4 binding to TBG is responsible for, with the help of salicylate, etc., so it can create certain problems. Or phenytoin, rifampicin, and phenobarbital, they called enzyme inducers. They lead to increased clearance of T4. Thus, if a patient is well controlled, or patient of hypothyroidism well controlled on thyroxine, if a person is put on phenytoin or rifampicin, etc., then the dose increment may be required. Similarly, Glucocorticoids, they can suppress the TSH secretion, and similarly impaired conversion of T4 to T3 with amiodarone, etc., or glucocorticoid. So this basic information is sometimes helpful in interpreting the test. This slide is very well known to you that there is a negative feedback mechanism. If T3, T4 are on the higher side, the pituitary hormone through hypothalamus, they are suppressed and TSH values goes down and vice versa. That is, if T3, T4 are low, TSH is going to be on the higher side. Now, I'd like to draw your attention to this particular slide that if T3, T4 on the lower side, the TSH starts rising, and this rise in TSH is rapid and starts much earlier. And then, of course, T3, T4 values are gradually rising. And decline of the T4 and T3 is slower and later. So to pick up a case of hypothyroidism, and in that situation, a single TSH value may give an much early indication that the person is going towards a stage of hypothyroidism. A word about thyroiditis. In thyroiditis, there is inflammation of the thyroid gland and there is leakage of the hormone. And in this leakage of the hormone, T4 or T3 or free T3, T4 values, it goes up and TSH got suppressed. And then over a couple of weeks, it heals by itself and the values start reaching towards normal. And then there is a transition phase. During this transition phase, one may find the TSH is low and T4 start recovering. Then ultimately, over a period of time, complete recovery takes place and T4 and T3, they become normal. So this is normal pattern of thyroiditis, which is self-limiting disease in general. Now, a word about TSH values in older people. In older people, a slightly higher value of TSH, because TSH is set at slightly higher value. So a value of TSH around 7 or 8 in older people is considered normal. So those variations one has to consider. Very commonly, we come to know, we are called to see the patient in ICU, etc. And due to acute general stage, then there is a disease called non-thyroid illness or sick thyroid syndrome, where T3, T4, especially T3 is converted into reverse T3, and then the value starts falling down. And in this situation, the low T3, low T4, and low TSH values are found, but they may not be part of the disease. They may be part of an adaptive mechanism. So thyroid function tests should not be measured in serious ill patient unless you know that the patient is already a known case of hypothyroidism or hyperthyroidism and requires evaluation. Generally, in any acute situation, as an adaptive mechanism, the thyroid hormone values are, especially TSH, T4, are going to be on the lower side. Now coming to the main assessment. As I mentioned, that in any thyroid setting, clinical diagnosis is important. What are you trying to look for? There may be a case of T3 is on the lower side, T4 is on the higher side, but unless you understand that what are you looking for, it may be thyroiditis, it may be hyperthyroidism. So a clinical impression is extremely important, and then one should proceed further. So first step is get an TSH done. Now TSH could be on the higher side, which is suggestive of hypothyroidism. TSH may be on the normal side, which may be a normal condition, or TSH may be on the lower side, which is suggestive of hyperthyroidism. So from this, we get a basic idea that we are dealing with either hyper or hypo, or maybe the patient is passing from hyper to hypo and that transition phase. Now, once we're talking about the low TSH, there could be three situations. One is the TSH is low, but T4 is on the higher side. This is classical hyperthyroidism or Graves' disease. In this situation, the diagnosis is made, and then only thing left is that thyroiditis. In thyroiditis, iodine uptake or technetium scan, that helps into confirmation of the diagnosis. And in that situation, radioactive iodine uptake is on the higher side, but in thyroiditis, it is suppressed. So the treatment is completely different. So one has to be careful in making clinical diagnosis based on TSH, and this gives only the blood hormone values, but the exact diagnosis is given by technetium scan or radioactive iodine uptake. Second situation is that there is TSH is low, but on the contrary, instead of being on the T4 being on the higher side, T4 is also on the lower side. So this is suggestive of central hypothyroidism or severe non-thyroid illness. And in this situation, one has to go further investigating, or T4 may be normal. Again, in this situation, there could be subclinical hyperthyroidism because TSH is on the lower side. So in this situation, ask for a T3 value. If T3 value is normal, in that situation, hyperthyroidism looks unlikely, so follow up the case. And if T3 value is on the higher side, then this is a case of hyperthyroidism. So that way one can differentiate the different stages of hyperthyroidism. Now coming to a state where TSH is high and we are suspecting hypothyroidism, again, there could be a situation when the TSH is high, T4 is low, and this is classical primary hypothyroidism. Other causes could be ablation of the thyroid or Hashimoto or transit phase as in the subacute stage of thyroiditis. Second is that TSH is high and instead of being T4 being low, T4 is on the higher side. And this is a very uncommon situation, what we call it thyroid hormone resistance or TSH resistance. So, or sometimes pituitary adenoma producing excess of TSH and causing overstimulation of the thyroid gland. So these are some of the conditions. So these are central hyperthyroidism, which is the case when T4 is on the higher side and TSH is also on the higher side. Commonly, this is the line that T4, if TSH is high, then it's a hypothyroidism and we consider that T4 is low. But sometimes T4 is in the normal range. In that situation, do consider subclinical hypothyroidism or transient thyrotoxicosis, or as I said, resolving stage where the improvement or stabilization of thyroid hormone is taking place. In this situation, ask for thyroid antibodies. If they are positive, then of course it confirms the Hashimoto's disease or autoimmune thyroiditis, and ask for T3 and T4. If T3 is on the lower side, this is definitely hypothyroidism. If TSH is high, T4 is normal, patient has no symptoms, then situation, it may be, it's unlikely the patient is having hypothyroidism. Such cases need to be followed up over a period of time. Now, this is the simplified form of the algorithm that you ask for the TSH, you ask for T4, and then if both are normal, the patient is absolutely normal, but ultimately it's the patient's symptoms which are most important, and then one has to decide. If you find that TSH is on the lower side and T4 is also on the lower side, which is normally uncommon, as we saw in the beginning, that negative feedback mechanism is violated. In that situation, it could be central hypothyroidism, or if TSH is on the higher side, T4 on the lower side, then of course classical primary hypothyroidism. And on the contrary, if TSH is on the higher side, like here, and T4 is also on the higher side, then this is overt hyperthyroidism. And between these are inappropriate secretion, etc., which I have discussed in the beginning. So that one has to consider that whether the normal negative feedback mechanism is being followed or not. Majority, around 95% cases, are solved by this mechanism with T4, T3, and TSH. I'll just like to briefly mention in my last slide that ultrasound sometimes comes to our help. Normally, ultrasound gives the structure of the thyroid gland, its size, whether it's cystic or any abnormal structure. And these days, with the help of blood flow studies of the inferior thyroid artery, we are able to find out whether it's thyroiditis or hyperthyroidism. And others, like technician scan radioactive iodine uptake. Increased uptake will help us in confirming the diagnosis of overactive thyroid gland, or decreased uptake will lead to situation of thyroiditis. And then, of course, if suspicious area is found, and that situation, FNAB can also be done, and thus a diagnosis of any thyroid disease can be completed. So friends, to conclude, thyroid diseases are common worldwide, and accurate diagnosis is important. And for that accurate diagnosis, first is you must have a good clinical impression and make an aim that what are we trying to look for. A casual report of low TSH, patient absolutely asymptomatic, and a test done as a routine in the executive checkup may have no meaning. It normally means there's some form of thyroiditis which is resolving of its own. But patient gets worried unnecessarily that some thyroid disease has occurred. So clinical impression, complaints of the patient, examination of the patient still remains supreme in interpreting the thyroid hormone values and early diagnosis, because early diagnosis is extremely important for the overall health of the individual. So with that, I end to my talk and back to the organizers. Over to them.
Thank you, Professor Kumar. This is a very concise but complete discussion on the topic. We will take the question and answer session at the end of this session.
Right.
And now to the to the next. I shall ask my co-chairperson to introduce the next speaker.
Hello, am I audible? Hello? Hello?
Yes, you're audible.
Yes, Satrajit.
Yes, sir, you are audible.
Good evening, all respected doctors. Today, this is my privilege that I am sharing the session with my teacher, Professor Shamul Kundu, on the Teachers' Day. Thank you, Dr. Vishwas and organizing committee for giving me such opportunity. Now, today's topic is the prevention of hospitalization in heart failure with reduced ejection fraction patient with type 2 diabetes mellitus. And speaker is Dr. K.K. Gangopadhyay, who don't need any introduction. He is MD, MRCP, CCST, endocrinology, and he is a consultant in diabetes, University of Hospital, Birmingham, UK, investigator in the several clinical trials, prize won in the UK, like Stephen Whitaker Prize, Wayne Wade Prize, Endocrine Society Prize, and NACI Prize. There are several publications in the national and international journal. I will request sir to start the session. Dr. Ganguly, sir.
Yeah, thank you, Dr. Roy. I'm just sharing my screen. So I hope my screen is visible and I hope my laser pointer is visible.
Yes, sir, visible.
Okay, fine. Good. Okay, so my topic today is, over the next 20 minutes, is prevention of hospitalization in HFrEF patient with type 2 diabetes. It's a very big subject. So I'm just going to concentrate on two areas. One is the ARNI and the other one is Sglt2 inhibitors. And I'm going to just touch upon a few of the commonly asked questions. So one is, which is better, ARNI or Sglt2 inhibitor? Other question is, does Sglt2 inhibitors cause hyperkalemia? And I will tell you why this question has come up. And what is the license indication for the eGFR level for the Sglt2 inhibitor? So I will touch on all of this in a bit. So diabetes is an unwanted path leading to heart failure. So all these hyperglycemia, insulin resistance, hyperinsulinemia, all collude with each other and then ultimately leads to ischemic cardiomyopathy, hypertrophic cardiomyopathy, and ultimately going into heart failure. So heart diabetes itself is an independent risk factor you may consider, occurring in about a quarter of heart failure patients and more than 40% of patients hospitalized with heart failure. And the impact of diabetes is that it increases the all-cause mortality, cardiovascular mortality, and heart failure hospitalization in patients. Now, the treatment options. So this is a busy slide. I'll not go through it. So this enumerates all the agents of anti-diabetic agents and anti-heart failure agents together as to where exactly in the mechanism, in the pathophysiology they work. So I'm just going to concentrate on two of these agents. So one is the ARNI or sacubitril valsartan combination. And now the latest guideline suggests that this is the first line therapy for all heart failure HFrEF patients. We know in heart failure, the natriuretic peptide system, it has got beneficial effect in the form of vasodilatation and reduction in fibrosis and natriuresis, but the nephrolysin, it stops this from, it degrades this. So if you inhibit the nephrolysin, you have got more of this that helps. And on the other side, the sympathetic nervous system overactivity in the RAS system is stopped by the valsartan, causing RAS blockage, at least one of the arms, which has got a beneficial effect. So both of these together leads to a lot of beneficial effect, which this suggests. So the angiotensin receptor blockage also increases the insulin sensitivity. Nephrolysin inhibition leads to a lot of positive effects. Now, The Paradigm heart failure was one of the largest clinical trials ever conducted in heart failure. So close to 8,500 patients, which was stopped early because the primary endpoint was met, which was reduce the cardiovascular death or heart failure by about 20%, cardiovascular death itself by 20%, worsening heart failure by 21%, and death from any cause by about 16%. So it not only improved this, but there was rapid improvement in patient-reported outcome measures. So this is very important. Sometimes we are very happy and pleased with ourselves that, oh, we have improved this. But is the patient happy is the question. And this trial had gone into detail into giving questionnaires to the patient, whether their physical functioning, whether their symptoms, whether their quality of life improved. And it did show improvement in all of these aspects. So the heart failure hospitalization was reduced irrespective of the glycemic status, whether the patient had diabetes or new diabetes, pre-diabetes or no diabetes, whatever, the heart failure hospitalization was reduced. And so was the CV death, a combination of CV death and heart failure hospitalization was reduced throughout. So the dysglycemia did not matter. Whether you have diabetes or you don't have diabetes, for both of them it works. So my topic was patients with diabetes and HFrEF. So this will work just as well for patients with diabetes as it will for patients with impaired glucose tolerance or non-diabetic. So it reduces the rates of 30-day all-cause and heart failure readmissions by about 26%, all-cause readmission, and 38% heart failure readmissions. In the Indian subgroup, also there was about 35% or 1/3 of the Indian HFrEF patients had diabetes in the sub-analysis. So you may try to extrapolate that to our population. So quality of life, which I was telling you, again, irrespective of the diabetes status, it favored the ARNI combination. And not only that, it reduced very marginally the HbA1c level, and there was a 30% reduction in new use of insulin in patients on ARNI. Now, the readmission, so 30-day heart failure, all cause, or 1 month, 2-month heart failure, or all cause, all were reduced. So what it shows that it works very quickly. So you need and prevention of clinical progression. So intensifying medical treatment, emergency admissions, ITU care, inotrope drugs, all were reduced. So this is so far as the ARNI is concerned. Now I'll quickly touch upon the Sglt2 inhibitors. Now, Sglt2, there are multiple theories about how the Sglt2 inhibitors work. There are animal data to suggest with empagliflozin that it reduces the LV dilation after an induced myocardial infarction. Long-term data with dapagliflozin, again, animal data to suggest that it reduces the fibrosis. We know that there is a switch over to ketone and fatty acid utilization, which in turn stimulates SIRT1 enzyme system, which removes harmful organelles. There is animal data again to suggest a reduction of the sympathetic activation, the norepinephrine, epinephrine level reduction in the animal studies. In the EMPA-REG trial, there was a suggestion that a rise of hematocrit was perhaps one of the most important reasons for the benefit. And this occurred irrespective of whether the patients were on diuretic or no diuretic. It was not attributed just to hemoconcentration. One of the postulation was at the kidney level, the sodium-potassium exchange was affected. As a result of that, you have less pressure in the glomerulus, so less pressure on the cells which produce erythropoietin. Otherwise, they will be transformed into different cells, and that wasn't there. So you have higher level of EPO, hematocrit, and better oxygen delivery. Inside the cells, you have got increased sodium-potassium exchange, which in turn increases intramitochondrial calcium and more ATP synthesis. So a lot of mechanisms. Apart from this, we all know about weight loss. We all know that it also helps in blood sugar control. I'm saying which also helps, but it is actually a diabetes drug. but reduction of blood pressure, reduction of interstitial fluid. So that's why new data is suggested that in patients with obstructive sleep apnea, you prevent onset of obstructive sleep apnea. And if you use it in patients with established obstructive sleep apnea, there is reduction of apneic episodes and oxygen level reduction is reduced. So this is the completed and ongoing cardiorenal trials with Sglt2 inhibitors. Now, I'll forget, just don't look at this because that's not the subject of today. We're looking at the heart failure. So you have got the CV outcome. We all are aware with this. The latest in the entries of Vertis and the score is the sotagliflozin. So here it is type 2 diabetes, but 10 to 15% of patients had heart failure. Now this, all patients had heart failure with reduced ejection fraction, but all of them did not have diabetes. And same with the HFpEF. The only study of type 2 diabetes with heart failure, patients with type 2 diabetes and heart failure, only study is the SOLOIST study. Unfortunately, it is not just HFrEF. It was a combination of HFrEF and HFpEF. So patients who were admitted in hospital for about 50% got the drug just at the time of discharge, and 50% got it within 3 days of discharge. There was a benefit shown in heart failure reduction. Unfortunately, the company funding the trial changed, and the new company suddenly stopped funding the trial, which is very unusual and quite a very embarrassing. And the trial was stopped due to lack of funding. So this is the ongoing, completed and ongoing trials. Now, if you look at the CVOTs, various CVOTs, you will see here. So a lot of people mention about class effect. I'm personally against the term class effect because I think each molecule deserves to prove itself. But if you really push me towards one class effect of the Sglt2 inhibitor, I will say it is heart failure. Because if you look here, you won't find the bright areas in everything except heart failure. All through, it's about 30 to 35% reduction, quite consistent reduction, statistically significant in heart failure. That is not replicated even in the renal composite endpoints, but heart failure, almost always it's there. For the Vertis CV, nothing was positive, but only heart failure was positive. So it clearly works. Now, for the dedicated heart failure trials, which I've just told you, so these two had diabetes, about 50% had diabetes, and here all of them had diabetes. Again, we see clearly there is reduction in the CV death and hospitalization due to heart failure. So with diabetes or without diabetes, it is the same. So if you tease out from the DAPA heart failure empire reduced, with diabetes, without diabetes, you get a similar sort of reduction of the heart failure. So now the next question is, which is better? Is it ARNI or SGLT2? So I chanced upon this article, a recent article. Herein, they said that there is no direct comparison available between these two therapy strategies. And data analysis using ITC method was performed, including 6 trials. So there is no direct comparison. So the indirect comparison suggested that both were the same. So hazard ratio of 0.93, clearly crossing the midline. So P of 0.28. So the question of which is better, the answer, closest answer is this in front of you, that both are similar in reducing the heart failure. So similar effects on CV death or heart failure prevention in patients with heart failure with reduced ejection fraction. Now, so the important thing which this paper suggested was that as compared to ARNI, if you add Sglt2 inhibitor, you get a further 30% reduction on the composite of CV death or hospitalization to heart failure. That is very interesting because with the ARNI or the Sglt2, you get a 30% reduction in hospitalization heart failure. Now, on top of the ARNI, if you add Sglt2, you get a further 30%. So here, 1 + 1 becomes 2. For the diabetes drugs, when they reduce blood sugars, blood sugar lowering ability, 1 + 1 never becomes 2, it becomes 1.5. But here, 1 + 1 becomes 2. So therefore, I looked at this article which had come up in Lancet last year. So in this modern era, what have we achieved in reducing hospitalization of heart failure? I think this is really a great advance that we have made in the last 5 to 10 years, which we hadn't made in the last 20 years. So here what they suggested, that if you use ARNI plus beta blockers plus aldosterone antagonist plus Sglt2 inhibitor, and you compare that with what we used to use 20 years ago or 10 years ago, just ACRB and beta blocker, what is the difference? So these were the 3 trials which we was based on. This was aldosterone antagonist, this was ARNI versus enalapril paradigm heart failure and DAPA heart failure. So here they suggested that if you use the modern medications, including ARNI, SGLT2, and you combine that with beta blocker and MRA, that compared to what we were using 10 years ago or even 5 years ago. These all have come recently, even 5 years ago. Now with this, you have got a whopping 40 to 60% reduction, CV death, CV hospitalization, or heart failure hospitalization, and in fact, all-cause mortality. So I can proudly now tell my friends that, look, in the field of medicine, we have made such an advance in the last 5 years that now as compared to what was modern even 5 years ago, we have got even 40 to 50% reduction in all-cause mortality and heart failure reduction with these. And what it suggested, the event-free survival after 55 years, if you compare it with ACE, ARB, and beta blocker, you get extra 8 years event-free survival if you use this combination. And mean survival, overall survival, you gain 6 years. This is no mean joke. You can tell the patient that I'm giving you 6 years of extra life when you're using this combination on as compared to what was used even just 5 years ago. So the ESC guidelines, which has just come out recently, it had suggested that you're using ACE for heart, HFrEF, beta blockers, MRA, DAPA or EMPA, but now the ARNI is recommended as a replacement for ACE inhibitors to reduce risk of heart failure, hospitalization, and death. And as far as SGLT2 inhibitors, for diabetes at risk of CV events, all of them have been named. CANA, DAPA, EMPA, R2, and SOTA. But diabetes with HFrEF, for them, only 3 have been named, DAPA, EMPA, and sotagliflozin, because these 3 have got dedicated heart failure trials, which have included patients with type 2 diabetes. And you can see class 1 reference evidence and level is A. So as far as ARNI, the guidelines have, the ESC guidelines have said that you use it as a replacement for ACE. It may be considered in patients who are also ACE naive. So those patients who are in history of angioedema or eGFR of less than 30 should be excluded. And remember, one may use a reduced starting dose. So what's the starting dose? It's about 100 milligrams twice a day, 49 plus 51 equal to 100 milligrams twice a day. Target is 200 milligrams twice a day. May use a lower starting dose if lower blood pressure and lower eGFR. So you double the dose at 2 weekly intervals, check the urea creatinine after 1 to 2 weeks after initiation. When would you stop at what level of eGFR? So less than 30, which it suggests. A reduction in GFR up to less than 30 is acceptable. An increase in potassium up to less than 5.5 is acceptable. If there is greater increase or the GFR is less than 30, then we have to stop. We have to be careful that there is at least 36 hours gap from the time when the ACE inhibitors were used to starting this. And of course, blood pressure may drop. So it's always important to tell the patient that you may expect dizziness and lightheadedness for the first few days. So what it suggested that it is recommended that ACE or ARB be replaced by ARNI in ambulatory patients. 2 studies have examined ARNI in hospitalized patients, suggesting benefit, and initiating ARNI in de novo in ACE naive patients. So those who have never been on ACE inhibitor or ARB, for them also initiating ARNI is what has been considered in this guideline. Now, the last few slides, I have finished 16 minutes, so I've got another 4 minutes. So last few slides, commonly asked question in CME, because in when early days, the canagliflozin, there was a hint that 1 or 2 anecdotal reports of hyperkalemia, and I was asked this question many times in the CMEs. So I kept looking for evidence to suggest, really, does Sglt2 inhibitors increase potassium? And this is the result. This is the data from the Credence trial, where it suggested that actually canagliflozin lowers the incidence of hyperkalemia by about 23%. So use of potassium binder, potassium more than 6, investigator reported hyperkalemia, all were reduced with canagliflozin and Sglt2 inhibitor in the Credence trial. You have got similar data with EMPA-REG trial, and in the DAPA heart failure trial as well, that dapagliflozin reduced the incidence of serious hyperkalemia, even in those with mineralocorticoid receptor antagonists, greater benefit there. So with the ARNI as well, you get less hyperkalemia as compared to enalapril. So nowadays, now this modern therapy not only is better, but it seems to be safer. Only thing is there might be slightly more hypotension. But as far as hyperkalemia, it is even safer than the previous therapies. Now, for lack of time, I will not go through this license indication in detail, but I can go through this in the question and answer session as to when, up to what GFR you can use. I can just very quickly touch upon it. So DAPA, EMPA, and CANA. For diabetes, 45 is the GFR below which you should not initiate. But if you're using it for diabetic kidney disease, it's 30. For HFrEF, heart failure, it is 30. So just for diabetes, 45. For heart failure or CKD, 30. Just remember like this, then it is easy to remember. So diabetes increases the risk of admission by 5-fold. Nowadays, the guidelines have suggested increased use of ARNI, and you have got fantastic results with combination of Sglt2 and ARNI, which is a network-generated data. So with that, I end. Thank you very much, and I'm stopping sharing of the slides.
Thank you, sir, for your excellent deliberation. Am I audible?
Yes, you're audible.
Yes,
hello,
yes.
Dr. Bandwal.
Hi.
Thank you, sir, for your excellent deliberations of the very relevant topic in today's clinical practice. We will take the question on these issues after this session. Now I request my co-chairperson to take the session. Thank you.
Thank you so much. So we know this year marks the centenary of insulin discovery, and insulin has come a long way over the past 100 years. And for the past 5-6 years, there has been very recent advancements with ultra fast acting as well as ultra long acting and other second generation basal insulins. And we are very honored to have none other than Professor Dr. Ganapathy Bhatwal, sir, to enlighten us on this topic. Sir needs no introduction, the current president of Endocrine Society of India, professor and head of the reputed endocrinology department of St. John's Medical College, Bangalore. Amongst sir's many esteemed affiliations include being the secretary of the ESI from 2006 to 2009, vice president of 2013 to 2014. Sir is a member of most of the reputed endocrine societies of the world. And among sir's many awards include the RSI SGI Oration Award 2014, the Nada Gowda Oration Award 2009, and Dr. Sunil Kumar Basu Oration Award 2019. Thank you so much, sir, for joining this conference. Over to you, sir.
Thank you, Dr. Sunetra Mandal. Thank you, Dr. Amitabh Biswas, for the invitation. I think you'll have to stop that slide share.
Stop.
Yeah.
Yes.
No, I'm not getting it still.
Slide, sir, you'll see the slide share in the bottom.
No, I'm not getting that share part.
Yeah.
You got it?
Yeah, it's coming soon. Just make it full screen.
Thank you, Dr. Sunetra Mandal. Thank you, Dr. Amita Biswas, for the invite. So in the next 15 minutes, I'll speak on the newer basal insulins. Why do you require that? The gold standard was glargine U100. Now, why do you require a glargine U300 or an IDAG, which we call it as a second generation? Comparisons between the two, head-to-head comparison between the new basal insulins, and the concept of time in range and its importance and the role of new basal insulins. So what's the difference between U100 versus U300? Now, you have U200 with degludec also, but then the PK/PD is the same. Whereas here you have a U100 which is acting differently and U300 which is acting differently. Why we wanted this change? The change was because glargine doesn't usually act for 24 hours. We say it acts for only 21, 22 hours. And that's the reason, especially in type 1 who have zero insulin, when you give glargine, you get a phenomenon known as dusk phenomenon, because if you're giving at bedtime, at around 7, 8 p.m. or 8 p.m., the glucose starts increasing because the effect of the glargine has waned off. And to combat that, we normally give, when the patient takes an evening snack, a small dose of a bolus insulin, which will take care of that also. That's how it is. So Glargine 300, this is a truly basal insulin acting 24 hours. So you have a lesser volume, that is the volume has been reduced by 2/3. And when you have a smaller volume, it's more compact subcutaneous depot with a smaller surface area, and you have a more gradual and slow release from the depot surface. Now, if you compare Glargine 300 versus IDAG, IDAG acts a little bit different. It strongly but reversibly binds to albumin via its fatty diacid side chain, resulting in plasma protein binding of more than 99% versus U300, which is precipitating at the physiological pH, and then it's slowly released. And because of, all insulins are neutral, whereas glargine is a little bit acidic. And that's the reason whenever you use glargine, you get a little bit of dull aching pain when you take the injection. So, and that's because of the acidic nature of that. Now, coming to the comparisons between the new basal. So we have had various phase 3 development programs for U300, that is the edition 1, 2, and 3, and the Japanese edition 1, where they compared glargine 300 versus glargine 100. So various regimens were used, the basal bolus, basal plus OADs in the insulin naive, or basal plus OADs. And the outcome was, it was non-inferior in A1C reduction. And very importantly, they had lesser anytime and nocturnal hypoglycemia with 300 compared to that of U100. See, all these trials are treat to target. So we expect the HbA1c to be the same. So that's the reason you always find in these trials non-inferiority in A1c reduction. But what we have to look into is how much hypoglycemia they produce. And you can see in the edition trials, the U300 produces lesser anytime and nocturnal hypoglycemia with glargine 300. And for the degludec, we had the begin trials, begin basal bolus, begin once, begin low volume, begin flex, and begin once Asia. Once again here, it was compared with glargine 100. There was non-inferiority in A1C reduction. But what's important is similar risk of anytime hypoglycemia, but more importantly, it produced lesser nocturnal hypoglycemia with IDAG compared to U100. So if you see the safety profile, the left-hand side, you can see in the edition trial, there was lower incidence of anytime and nocturnal hypoglycemia. The upper one is anytime. Once again, it favored a 19% better outcome with U300. And the lower one is for nocturnal hypoglycemia. That was once again better with the U300. So anytime nocturnal hypoglycemia lesser with U300 compared with U100. On the right-hand side, once again, the upper one, anytime it was non-inferior to U100, but if you take only nocturnal hypoglycemia, once again, definitely IDEG scored over U100. Now, a comparison between glargine 300 versus IDEG for glycemic variability. So when they compared it using a euglycemic clamp, you find that 20% lesser within the variability with U300 compared to IDEG 100. Also, in this, they found that when you compared 300 versus IDEG 100, when they used the IDEG, there was a 22% greater peak with IDEG 100. So the levels of insulin were more with 100. And if you also compare the glucose infusion rate, that was actually lesser with U300, telling that the variability was lesser with 300 compared to IDEG 100. What about glycemic improvement? All the studies are treat to target, and you find no change in that. So whether you're using it with an A1C high or lesser, you find that they are similar. Now let us come to head-to-head RCTs on efficacy and safety. We have two studies, the BRIGHT study and the CONCLUDE study. The BRIGHT study was a multi-center, open-label, 1:1 randomized, active control, 2 parallel arm, non-inferiority study in adults aged more than 18 years, at least diabetes duration of more than 1 year, A1C more than 7.5 to 10.5, less than that, and no prior insulin. 24-week study, and there was a 7 days post-treatment. So the starting dose for U300 was 0.2 units per kg, or in IDEG, it was 10 units per day as per labeling. Once again, treat to target studies. So there was a non-inferiority in A1C reduction. The A1C was similar in both. So what is important is, as I told you, you should look in the hypoglycemia. So in the titration phase, which is the first 0 to 12 weeks, confirmed hypoglycemia less than 70 or confirmed hypoglycemia less than 54 was lesser with 300 in the titration phase compared to that of degludec. Also, the event rates were also lesser with 300 in the titration phase. So you can say in the titration phase, where we actually make a lot of changes in the dosages of the basal insulin, the confirmed hypoglycemia was lesser, and the incidence of that and the event rates were also lesser. The conclusion actually from this study was by Julian Rosenstock. He told there are a lot of similarities than dissimilarities. The only one difference was in the titration phase where U300 fared better than U100 degludec. CONCLUDE study. So this was an open label, randomized, active control, 2-arm parallel group multi-center study comparing IDEG 200 versus glargine 300 in Europe and North America. We don't have the U200 of IDEG in India. So it was to compare the safety and efficacy of IDEG versus 200 versus glargine 300 involving 1,600 participants. This was designed to test superiority, 1:1 randomization, BMI less than 45 and A1C less than 9.5, and they had to be on a basal insulin plus or minus OADs. So what happened here was in the first 16 weeks of titration, they had a defective glucose meter used throughout. SMBG was overestimated. The patients were likely to be overdosed. There was a high risk of hypo and severe hypos because of this, which was unprecedented because they had used a defective glucometer. And then you had up to 36 weeks of transition period. There was a mixed use of defective and new glucometer and different use of defective glucose meter for different length of time. And the second half, the use of new glucose meter, we do not know what is the impact of titration and transition periods on the second half of this. So to conclude, what you could see here was the main outcome, that is symptomatic, it was non-inferior. There was no much change. It failed to meet the primary endpoint, and hence the secondary confirmatory endpoints cannot be evaluated for statistical significance. So since it did not meet the primary, there's no use telling that, yes, it did better in nocturnal symptomatic or severe hypoglycemia was lesser with degludec, or overall symptomatic nocturnal severe hypoglycemia as well. The better with the U200 because it did not meet the primary outcome. Now we go to the next aspect, concept of time in range and its important and the role of new basal insulins. So you all know this glycemic variability. It's very important to minimize variability because you can have somebody having a glucose of 350 and also having below 70. So, but then he has an A1C of 7. So you can see here, you have a person, 7%, but only 18% is in the time in range. The second person, HbA1c is 7, 63% is in time in range. And another person, you find that 7%, but 100% is in time in range. So what is this concept? So you must at least see that 17 hours of the day, more than 70% of the time, it should be in the time in range, that is between 70 to 180. And you should minimize time above range, that is 180 to more than 250, and minimize also time below range. So it should be less than 1 hour. So level 1 is 18 to 181 to 250, level 2 is more than 250. And for hypoglycemia, the level 1 is between 54 to 69 milligrams per deciliter. And for level 2, it is less than 54. What is it important? What are the outcomes if you don't maintain it in this time in range? Even if you find that the time in range is reduced by 10%, retinopathy risk increased by 64%, nephropathy by 40%, neuropathy by 25%. So initial evidences show increase in surrogate markers of macrovascular complications like abnormal carotid intimal medial thickness. This concept actually started in 2012, and now in 2021, the ADA has come out that CGM as an important tool for hypoglycemia prevention. What should be the time in range for type 1 and type 2? More than 70% should be between 70 to 180, less than 25% above 180 to 250, and less than 5% above 250. Less than 4% should be below 70, and less than 1% below 54. For type 1 or elderly, at least 50% you must have in the time in range, and less than 1% in the time below range. And for pregnancy, we want maybe in type 1 the same, but the target here is not 70 to 180, it is 63 to 140. And for type 2, that is GDMs or type 2 with going in for gestation, the pre-gestational type 2 diabetics, probably 90% should be in the time in range. Now coming to type 2 diabetes, CGM studies of time in range of U300 versus U100 IDEG. So a small study where they compared the efficacy and safety of 300 and degludec on glycemic control using CGM. 5 days they were on that. The mean percentage of time within the target range was looked into. So you can see here in this trial. There was comparable time in range for glargine 300 versus IDEG, with the time below range markedly lower for U300 across the categories of hypoglycemia. So hypoglycemia in this was lesser in the U300 versus IDEG. Another study where they used a flash glucose monitoring, similar type, small study, 24 patients of type 2, 12 each, looked into the same outcome. Once again, here what they found was the percentage of time in nocturnal hypoglycemia with glargine 300 was significantly lower than that of IDEG treatment. And then there was what is known as a OneCare, which was the real world evidence in adults with type 1 diabetes using CGM. So all patients with adults with type 1 for reasons who switched to either U300 glargine or IDEG 100, they had to be stable on this drug for at least 3 months. And then they followed them up for 1 month, and then they were put on a CGM for 14 days. The primary endpoint was percentage of time in range, and the secondary was percentage time above range, time below range, and the safety, hypers and hypos, how much were there. So what they found here was there was a similar time in range, time above range, or time below range profiles between U300 glargine and IDEG 100. But then in the night period, the differences was actually better for U300. So the time in range was better between either you take 70 to 140 or 70 to 180, or for that matter, time above range more than 180 was actually better with U300 compared to that of IDEC 100. So one case study showed that in real world settings in adults with type 1 diabetes, the effectiveness and safety of glargine 300 was similar to IDEC 100 in those switching from first generation basal insulin. However, more people on glargine 300 remained within target glucose range at night versus IDEC 100. To summarize, though glargine 100 was the gold standard basal insulin, U300 offers advantages over glargine 100 with lesser hypoglycemia, which could be anytime and nocturnal, lesser glycemic variability, and lesser weight gain. IDEC 100 was equally effective with U300 with lesser hypoglycemia, but mainly during the nocturnal phase only compared to U100. And when there was a head-to-head comparison, U300 fared better with lesser hypoglycemia during the titration phase. Glycemic variability and time in range is associated with increased risk of severe hypoglycemia, diabetic complications, and reduced quality of life if you are not in the time in range. So second generation basal insulins demonstrate improved glycemic variability than other insulin regimens. Among the second generation, U300 compared to that of U100 IDEC demonstrated lesser risk of hypoglycemia during the titration phase and better time in range profiles. Thank you for patient hearing.
Thank you so much, sir, for your excellent deliberation. So now, are we ready to take all questions for this session together?
Any questions?
No. Thank you, all the speakers. From the chairperson's perspective, let me open the discussion, open the session for discussion. Is there any question in the chat box? I haven't found anything. So if any comment is there or any other question somebody can ask, we have all speakers together. So please mention the speaker and then you can ask the question or you can add some comment on that, each of the issues.
Yeah, can I just ask a question to sir?
Yeah.
Yeah. First of all, thank you to all the speakers for the very wonderful talk. It was very enlightening to listen. It's a delight to listen to all of you always. To sir, my question is that you have very the role of ARNI and as well as Sglt2 inhibitors in the role of heart failure in patients with diabetes. My question is, when do you prefer to start these drugs together, especially after discharge from hospitalization? Once the patient has been discharged from hospitalization, would you start ARNI and Sglt2 inhibitor at the same setting, or would you wait sequentially add one after the other, or you add the Sglt2 inhibitors after a brief period of time once the patient has been stabilized on ARNI?
Yeah, so that's a relevant question, Amarto. So I think with the Sglt2 inhibitors, apart from the soloist trial, all of them were after an event, well into 3 months after the event. So we don't have that much evidence of starting Sglt2 inhibitor during an episode of heart failure. We have got some evidence with the ARNI just at the time of discharge. So what the guidelines have said, that if you consider starting ARNI, you should just do it as a discharge medication. I never myself start Sglt2 inhibitor when the patient is admitted with heart failure. I never use it as a discharge medication as well when they're admitted with heart failure. I always see them back in the clinic when things have settled down, then I start the Sglt2 inhibitors. Regarding starting both Sglt2 and ARNI together, the ARNI itself can cause hypotension, and so can the Sglt2. Some individuals are particularly prone to get hypertension with the Sglt2. So starting both of them together might precipitate a much larger drop in blood pressure than what you want. So therefore, I would never start them together. Actually, I would also not start ACE-ARB with Sglt2 together. Again, I will give a bit of a gap, say about at least 2 to 3 week gap before I start them.
Thank you, sir. You're absolutely, I mean, totally agree with you, sir, regarding the hypertension that it might cause both of the drugs and started together. Thank you.
May I ask Professor Bantwal, sir, a question?
Sure.
So we know that for U300, we need a slight dose increment in comparison to U100 glargine. So when we are shifting a patient from U100 to U300 glargine, what should be our correct approach, sir, regarding the dose increment?
So actually, if you see, personal communication is I use the same dose because I haven't found that 10 to 12% increase in the dose I mean, this is my experience, of course, but then package insert says you require a 12%, 10 to 12% increase in dose. I normally continue with the same dosage itself. But then if the levels are not coming down, then I updated it because that has been the observation.
Thank you so much.
Professor Bantwal, sir, I have a question. First of all, happy Teachers' Day, sir.
Thank you.
Thank you for the nice talk. Sir, it's a common question in many CMEs, actually, from most of the speakers do ask, sir, regarding the second generation basal insulins. What are the patient profile you choose to prescribe the second generation basal insulin over the first generation glargine U100?
See, one thing is very much sure. U300 is better than U100 in all aspects. The only difference is package insert wise 10% increase in dosage. I think we should slowly shift to U300 itself. So if you're telling U300 versus 100, without any doubt, U300 is superior. So only difference is the cost factor. And now that they have come with the cartridges, the cost also has come down. Of course, yeah, it's still marginally costlier than the U100. If that is not a factor, I think all of them should be put on this because it's definitely better. No, it's a 24 hours action, less hypoglycemia. Everything is better with that. So it is time we change to U300 if cost is not a factor.
Thank you, sir. Thank you.
Good evening, sir. My question to, may I ask one question?
Yes, please proceed. Please proceed.
My question to Dr. Surender Kumar, sir. Excellent talk, sir, and we completely agree that we are not going in the right direction regarding that we should diagnose mostly clinically, but rather that most of the patients who come with the TFT, they will have with an laboratory test in their hand. So in post-COVID era, we have seen lots of patients are taking many over-the-counter supplements and vitamins. And what is your take like regarding the different interference that can happen, like biotin interference in this patient regarding they are coming with the abnormal TFTs? Any advice for this, sir?
Professor Surender Kumar. Professor Surender Kumar, sir.
Sir is there, but...
Yeah, he's there.
So in the meantime, may I ask Professor Bantwal, sir, another question, sir?
Sure.
So I want to know your opinion, sir, on biosimilar glargine, sir.
Well, if you say they are actually almost similar to that of the other drugs. The only thing is once again, the personal opinion is we find that the requirement of insulin may be a little bit more when we actually use a biosimilar compared to the innovator brand. So that's been the observation from whatever we are using it. But then if you see the trial evidence, they say it's almost the same. There's no much difference. But observation has been we require a higher dose when you use a biosimilar compared to that of innovator brand. That's our observation. And of course, even the side effect profiles, the adverse effects, if at all, which happens, are more with the biosimilar than that of the innovator brand.
Thank you so much, sir. We could not get Professor Kumar, sir, with us now.
So let me, now it's almost the end of the session. We have already reached 9 p.m. The next session is waiting for us. So I request Sunetra to close and thank all of the speakers.
Thank you so much. We are extremely privileged to have all of you as our esteemed speakers. So we should conclude the session now to make place for the next session. Thank you so much.
Thank you. Bye, Dr. Kalyan. And
bye, Prantual.
Yeah.
Thank you, sir. On behalf of Bdcon, we thank you for your excellent talk. Now we are moving towards the last session of our conference for this year. And this is an exciting session of debate, like yesterday's last session. To moderate this debate, I will invite Dr. Amartya Shankar Chaudhary and Dr. Deep Datta for chairing this session of debate. I think both of the speakers, both of the chairperson has already been introduced, and Deepda and Dr. Amartya needs no introduction. I will directly ask or request them to conduct the session. Over to
Hello, very good evening. I think we are saving the best for the last. This is a very exciting topic we are having here today, which is, should metformin remain the first choice of drug for all patients in type 2 diabetes? This is especially relevant because certain societies like the European Society of Cardiology have gone ahead and placed some other agents, which is typically we are not using as first line agent in our practice. So should we change our practice or not? We have two very eminent speakers. So let me invite Dr. Amartya Chaudhary to take the session forward and introduce both the speakers for this debate session. It's going to be very exciting next 50 minutes or so. Over to you, Dr. Amartya.
Thank you, Deepda. It's a really pleasure to moderate the session along with you. It's a very exciting debate which is going to happen now. This is the last session of Bdcon. And for this debate, we have two dynamic and prolific speakers, which are quite well known and probably do not need any introduction. But for the sake of doing the honors, can I have the introduction between style of Dr. Zubin Jacob, please? Yeah, Professor Zubin Jacob needs no introduction. He's a professor and head Department of Endocrinology of Christian Medical College, Ludhiana. He's executive editor of IJM, and he has received the international fellowship at JJR MacLeod Center for Diabetes and Endocrinology, Aberdeen, United Kingdom. He has numerous publications, and he has also authored 3 books. And the second debater for today's session is Dr. Supratik Bhattacharya. Can I have the slides of Dr. Supratik? Dr. Supratik Bhattacharya is a renowned practicing endocrinologist at Kolkata. He has numerous publications. He's currently associated with Ambri, Salt Lake, Apollo Sugar Clinic. Again, a very dynamic speaker in many national as well as regional forums. So I would invite them both to start the debate. You'll have 15 minutes each for the debate and 5 minutes for rebuttal. So for the first speaker who will be speaking for the motion, should metformin remain the first choice of drug for all patients in type 2 diabetes, I would invite Professor Zubin Jacob. Sir, the floor is yours.
Thank you. Thank you for the invitation. And I think my job is fairly simple. It's to convince you. And I'll have 6 reasons to convince you why we should continue using metformin as the first drug for patients with type 2 diabetes. So the answer to this question is yes. And I'll try and give you 6 reasons to convince you why this is the right answer. I think first things, we already know that we've had 100 years of insulin now. You have to remember that the herb from which metformin is derived, it's a French lilac, has been around treating diabetes for 300 years. So that means even before we had a diagnosis of type 2 diabetes, French lilac as a herb was used to treat patients with polyuria and polydipsia. So I think it was the beginning of 20th century that they found out that the effective agents were guanidines, and metformin was one of the agents which was purified from there. And I think just a little of history, that it was a French physician who first published this paper. So he was not actually looking for metformin as an anti-diabetic drug. It was actually purified as an influenza drug. But Jules Stearns found that patients who were getting it had better sugar control. And that's when he first did the trial of metformin. It was 1958, and we've had this drug for 60 years now. And within the year, this paper was published, it came into, and he called this drug glucophage because he found that it eats up sugar and removes glucose from the circulation very effectively. And within 1 year of that, in 1958, metformin was in the British National Formulary. Within a year, it was used all over Europe. In about 10 years' time, it was available in India. It did not reach North America for a long time. 1972, it reached Canada, and it was only after publication of the UK PDS in 1994, metformin actually found its way into into approval from the FDA and into the largest market for diabetic agents, which is the United States of America. So I want to highlight here that the 21st century actually belongs to metformin. Though we've been having this drug for 300 years, I think it first got its rightful place in the year 2000. About 2002 was when metformin became the most prescribed oral anti-diabetic agent, and it still continues to be the most prescribed agent. 2005, for the first time, it was not the ADA-EASD guideline, it was the IDF guidelines with input from countries like India and Europe, which first put metformin as a first-line drug. This was 2005, and it has remained there. ADA, EASD, IDF, it has all remained there for the last 15, 16 years. I think Dr. Deep already mentioned that there are some societies which have come up with slight alterations and keeping metformin as a second-line drug. You have to remember 2011, metformin became an essential drug onto the WHO list. There are only 3 diabetic drugs which are on the WHO essential drug list, and metformin is there. So this is, I think now 2021, this is the month of September. This is 9 o'clock in the night, and Dr. Supratik is going to tell us that we need to remove metformin, and 20 years is more than enough of metformin. It does not belong to 21st century anymore. And I think I'm trying to convince you that this is not the case. We have not heard the last of metformin as of yet. One of the reasons we have not heard of last of metformin is we still don't know what is the mechanism of action. We understood that the herb reduced blood glucose. We found out what was the chemical which reduced blood glucose, but how it reduced blood glucose, we don't know. Unlike some of the newer agents where we devised the drug after we know the mechanism. We understood GLP-1 physiology, we made GLP-1 agonists. We understood Sglt2 inhibition, then we made Sglt2 inhibitors. But metformin, we never understood how it reduces blood glucose, and we are slowly evolving the mechanism of action. Our older thought was it inhibits gluconeogenesis, reduces hepatic blood glucose output, and that is how it controls blood sugar. Then we understood it does have some peripheral action by increasing glucose uptake, both in the muscles and in the adipose tissue. And I think in the last 10 years, there has been more thoughts about that. The primary mechanism of action may not be at the liver or the periphery, it may be right in the gut, where it can or where it does inhibit glucose uptake, and that may contribute majorly to the anti-glycemic effect of metformin. And again, once we knew GLP-1 physiology, we understood that metformin can increase GLP-1 production. And once we understood the importance of gut microbiota, there are now plenty of papers which have come out which suggest that metformin improves gut microbiota, makes it a much more metabolic friendly microbiota. So we have still not understood the mechanisms of action, but we are learning every day new things about metformin. I think the most exciting thing about metformin is its molecular basis. And if you look at the molecular basis, you see that there's a very small enzyme right there below the mitochondria, below adenyl cyclase, which is called AMP kinase, and metformin activates AMP kinase. Now, AMP kinase is a very tiny enzyme, but which seems to have a lot of benefits activation. And actually, when you exercise, you activate your AMP kinase. So metformin is like an exercise mimetic. And AMP kinase activation, AMP kinase is actually the fuel gauge of our mitochondria, or of our within our cells. And activation of AMP kinase, we know, increases lifespan in some nematodes, not in humans as of yet, we don't know. But in nematode, it increases lifespan. Many cancers, it decreases both the incidence of cancers and also division of the cancerous cells. There is plenty of evidence that it improves depression, decreases the decline in neurodegeneration. So there are many, many benefits. So when Dr. Supratik is going to talk about removing metformin as a first-line drug, he's going to talk about what he has learned in the last 5 years. And I think what he has learned in the last 5 years has come from large commercially driven cardiovascular outcome trials, starting in 2015 with the EMPA-REC trial on empagliflozin. And subsequently, you see these red boxes, NEJM articles in the red boxes, LEADER, SUSTAIN 6, HARMONY, CANVAS, REWIND, all of these showing positive cardiovascular outcomes, and subsequently heart failure trials showing positive outcomes in heart failure, positive outcomes in renal trials. And this is what he's going to convince you requires you to pay more attention to these new drugs and remove metformin from its place of pride, or the 20th century drug of choice. I think before we go there, I'll just talk about a little bit about cardiovascular information that we have. We do not have trials like EMPA-REC trial or LEADER involving thousands and thousands of patients in a randomized control manner. We have small trials. We have UKPDS 34, which is a sub-study, about 700 patients, obese patients on metformin, definitely showing cardiovascular benefits, both in terms of death and MI. You can see 39% reduction in MI, about 36% reduction in death. Very similar to what these big trials that Dr. Supratik is going to talk to you about. But what is more interesting is UKPDS taught us metabolic memory. And what UKPDS 34 is going to teach you is what we call metformin memory, that patients who are on metformin continue to have better macrovascular outcomes even after they stopped metformin. So that is something that UKPDS 34 showed, that in addition to metabolic memory, there is something called metformin memory as well. There is a small trial, I'm sure Dr. Supratik doesn't know. Most of us don't know. I only came to know because I was searching for it. This is a direct head-to-head trial of metformin versus glipizide, not published in Diabetes Care, did not get its attention because it came from China. We don't really believe in China as much. But if we do believe this small study, not many patients, about 300 odd patients, compared head-to-head with metformin versus glipizide, and the 3-point MACE outcomes, you can see a hazard ratio of 0.54. Significant reduction. But I'm sure these are not the studies which are going to stand with the studies that Dr. Supratik is going to show you, all these CVOTs. But let us look at these CVOTs a little more carefully. I'll start by looking at the EMPA-REC trial. Now, this is what is happening to metformin in the SGLT2 CVOTs. Let us start with the EMPA-REC trial. Remember, 74% of patients at baseline were on metformin in the EMPA-REC trial. Now, let us see the hazard ratio. All the 3-point MACE, you can see 14% reduction. Look at what happens if they were on metformin. No difference. You see the confidence interval, 0.77 to 1.19% reduction, not significant at all. Look at the 26% who are not on metformin. Significant cardiovascular benefit, 28%. Look at that hazard ratio, 0.56 to 0.93, which suggests that if patients were given empagliflozin on top of metformin, they're not going to benefit. All this benefit that they saw with empagliflozin was driven by the 26% of patients who are not getting metformin. Very similar data with CANVAS, 0.91, 77% on metformin at baseline, no benefits among metformin users, no MACE benefits. But among no metformin users, that is a 23% small minority, there is 24% reduction. Altogether, these are these patients who are not getting metformin, which is driving the hazard ratio and the cardiovascular benefits that we've been talking about all this time. We have not seen these data from these companies. We've heard so many talks about EMPA-REG Canvas, but we have not seen this data that suggests that with metformin, there is no cardiovascular benefit of empagliflozin or canagliflozin. Ertugliflozin, I'm not going to talk about because altogether it did not have any cardiovascular benefit. Whether you're on metformin or not on metformin, it is not going to have any cardiovascular benefit. Now let us look at what the other trials with GLP-1 analogs. Major of them, 2016, huge trial, 10,000 patients, liraglutide, LEADER trial. And you can if you can again see the highlighted portions, 76% of patients were on metformin at baseline. Look at the hazard ratio, 13% reduction in MACE. Makes it a darling of cardiovascular physicians, makes it a darling of cardiologists. That is the reason why it is now overtaken metformin, GLP-1 analogs. The cardiologist societies want people to prescribe GLP-1 analogs versus metformin. Look at patients who are on metformin. No protection offered to patients who are actually taking metformin. That is 76% of patients who are on metformin. The hazard ratio, as you can see, the reduction is only 3%. Look at the confidence interval. Does not make any difference, no significance. Look at the patients who are not on metformin. 21% reduction. The confidence interval is very valid. So that means all this benefit of liraglutide is only among patients who are not taking metformin. No benefits on patients taking metformin. Albiglutide was the only one which did not show this kind of, and we don't have this drug anymore in the market. So let us forget this drug. Dulaglutide, Sustain, Semaglutide, Pioneer did not report this data separately. So what does this all mean? That means, should we believe the cardiologist and say that by adding metformin first and then adding SGLT2, GLP-1, we are actually not giving our patients any cardiovascular benefit? We should avoid metformin and just put them on empagliflozin or liraglutide. We should not add, because metformin seems to mitigate the cardiovascular benefit from the newer agents. I think I'll completely disagree, and that is the reason why none of these companies have shown you this data. What has really happened in a randomized control trial when we have placebo on one side? We are hoping that the risks are equal on both sides. It is not equal. Patients who are treated with metformin already have significant cardiovascular protection. If you believe in UKPDS 34, you believe in the Chinese study, this is as high as 45% risk reduction or 34% risk reduction. With that kind of risk reduction, if you're now adding a newer agent, you're going to really, really have to work hard to get any additional cardiovascular benefit. And that is what we saw in all these large trials, which I'm sure Dr. Supratik is going to talk about. So that is why patients treated with metformin did not show any benefit with SGLT2 inhibitors or GLP-1 agonists. Those who were not treated with metformin, SGLT2 inhibitors, GLP-1 had a much more balanced scale, showed you those benefits, did not show you those benefits among metformin treated individuals. So I think, so what does that mean? I think 20th century, 21st century, metformin story is not finished. Lots of ongoing studies are going on. If you look at clinicaltrials.gov, there are trials on metformin, treat frailty in obese seniors. There are trials. There is VA Impact trial, which is also a cardiovascular trial, placebo-based with metformin in patients with pre-diabetes. There is a TAME trial, which is again a large trial, 3,000 individuals, which is not looking at diabetic patients. This is looking at non-diabetic older individuals, whether metformin is going to prevent heart disease, going to prevent cancer, going to prevent neurodegenerations like dementia. So other ongoing trials, there is a PREDIS trial, which is looking at microvascular complications. So metformin story is not over. When we talk about SGLT2 inhibitors, we talk about heart failure data, we talk about renal data, but metformin is going to show things from the looks of it. It has benefits beyond glycemia, beyond heart disease, on cancers, on frailty, on longevity, on things like neurodegeneration, depression. So I think these are things that none of these newer agents are going to handle. And that is the reason why I think the 6 reasons that metformin continues to be the first line drug, and we should say yes to using metformin in all our patients who can tolerate with type 2 diabetes. One reason is the knowledge that we have, or the usage, is more than 300 years old. None of the newer agents is going to come anywhere close to this. We have not completely understood the mechanism of action. There are more and more evolving mechanism of action, more new things we learn every day about metformin. The most interesting of them is the AMP kinase activity, and AMP kinase activation is definitely leading to longevity in certain animals, but my guess is this would have some benefit in humans as well. There is benefits in cancers, in neurodegeneration. We have seen the dramatic reduction in death and MI in the UK-PDS34, but it's a small study. We've seen another small study showing 46% reduction when compared with a sulfonylurea. And most importantly, we have seen that even in the larger trials, which I'm sure Dr. Supratik is going to talk about, metformin treatment does not give you any additional benefits with any of the newer agent, whether it's an Sglt2 inhibitor or a GLP-1 analog. The only one which showed no major difference was albiglutide. Unfortunately, Dr. Supratik will not be able to prescribe albiglutide because it has been withdrawn from the market. So none of the current agent is going to replace metformin. And that is the 6 reasons I think we should continue saying yes to metformin. Thank you. And I hope I have made my point. And I'll be very happy to hear Dr. Supratik's version of things.
Yeah, thank you, Professor Jacob. There are a lot of interesting points in favor of metformin, our childhood friend. And let us hear what Dr. Supratik Bhattacharjee has to say against the motion. Dr. Supratik, kindly.
So, first of all, thank you, Dr. Amitabh Biswas and Dr. Amartya S. Chaudhary and the entire team for this kind invitation. It was a pleasure listening to Dr. Jubril. And I'll just take a second to put up my slides. And please give me a shout when you start seeing the slides, yeah?
Yes, it's visible.
Okay.
Yeah.
So let's not confuse what we are debating about today. So the topic for debate today is, should metformin remain the first choice of drug for all patients with type 2 diabetes? So this is the topic of debate. And we are trying to understand whether metformin is for every single person that walks into your OPD who is newly diagnosed of type 2 diabetes, and whether you can prescribe metformin for one and all. So that's what it is. And of course, we know that half-truth is almost equal to a lie, and beware of which half of the truth you're trying to catch on to, because you might have gotten the wrong side. This is a famous scene from Mahabharata, and you are aware this Pitamaha Vishwa, unfortunately, was fighting. He was a prolific fighter, but unfortunately, he was fighting for the wrong side. And that's why, unfortunately, at the end, he was defeated. So let's look at a few of the limitations that we're going to talk about eventually, which for the metformin per se to be prescribed as first line in all patients. So first, already Dr. Jubin has made my life so much more easier, because he mentioned that it cannot be used in those patients who are metformin intolerant. Second is, we are also aware of situations where there is increased chances of lactic acidosis. Patients with a background of established atherosclerotic cardiovascular disease, heart failure, and CKD, and I will be obviously talking about the various evidences that are in support of this. Patients who are insulinopenic and are coming to you with gross osmotic symptoms, again, you should be considering insulin ahead of anything else. Patients newly diagnosed and considering emergency surgery, again, you'd be considering insulin rather than you'd be starting off with metformin per se. And also patients who are still treated optimally for glycemia, and still getting benefits in terms of microvascular endpoints and also the legacy effect that we see from UKPDS even before metformin came into vogue, and we know that insulin has been there for the past 100 years. And you just saw Dr. Jubin showing you the timeline of introduction of metformin in our clinical practice. So the good physician treats the disease, the great physician actually treats the patient as a whole. So let's not have a tunnel vision and try and have a broader perspective when it comes to our patients. So this is the clear guideline that we have in 2019 from the EAC, and you can see in here, type 2 diabetic patients who are drug naive and has got an established atherosclerotic cardiovascular disease or are at very high risk of cardiovascular disease, target organ damage or multiple risk factors, you should be considering Sglt2 inhibitors or GLP-1 receptor monotherapy ahead of metformin. So there is absolutely no doubt about this. This crystal clear about what they're trying to imply in here. And the other situation where these are negative, then only you think about continuing with metformin monotherapy. This again is the recommendation coming in from 2019 ESC guidelines on diabetes, pre-diabetes. And you can see in here, Sglt2 inhibitors have got class 1 level A evidence versus metformin, which has got 2A class C evidence in those patients who are at high risk, as we had already talked about. So obviously, although metformin had remained, the blue-eyed baby for all the endocrinologists so far, it seems that times are changing and you should be adopting the change. Right, so this is the other algorithm from AAC that I wanted to show you. So beyond lifestyle therapy and ongoing glucose monitoring, independent of glycemic control, if there is established atherosclerotic cardiovascular disease or CKD, the recommendation is to start with a Sglt2 inhibitor or a GLP-1 receptor analog with evidence. So metformin is first choice. Well, there's increasing discussion whether metformin should continue to be the first choice anymore. Other anti-hyperglycemic medications exhibit pleiotropic benefits, organ protection, which is ultimately the goal of treating diabetes. So it's not just getting glycemia to control, but also giving organ protection. And we're moving away from secondary prevention to primary prevention. So available studies fail to provide strong evidence due to either small sample size or short duration of the study. And recent data from the Sglt2 inhibitor cardiovascular and renal outcome studies demonstrate additional protection from diabetes complications. We are in an era where we do not blindly practice based on whatever experience we had, because that's not going to be good enough. Neither we are going to be standing strong if we are legally questioned. So we are in an era where we practice evidence-based medicine and we are practicing science. So any opinion that you have at this point of time based on experience doesn't count anymore. Metformin monotherapy for adults with type 2 diabetes, and this is coming from the Cochrane and 18 randomized controlled trials. And you see the number of patients were about 10,600 odd patients were looked into. And the conclusion drawn from this was that there was no clear evidence whether metformin monotherapy compared with no intervention, behavior changing interventions or other glucose lowering drugs influences patient important outcomes at any point. So is there a clear evidence in a head-to-head trial of a benefit of other agents over metformin? Well, the one solo study that Dr. Jubin had shown is the only one that I saw, and I'm sure most of you would be seeing it for the first time, and I am sure it's not so significant as to come up or be cited because, unless you actually actively search for it, you would have never heard about this. So far, we do not have any direct head-to-head primary cardiovascular outcome trials comparing metformin with agents like Sglt2 inhibitor, for example, let alone first generation sulfonylureas, because we are hardly using that anymore. And cost will remain a consideration even if Sglt2 inhibitors were found to be superior. But the point is, we are getting to a point where we are not looking at the immediate cost, but at the cost of preventing long-term complications and hospital admissions, etc. So again, have a broader perspective, look at the patient as a whole rather than having a tunnel vision. So metformin and cardiovascular outcome trials, it's very unlikely that you would have dedicated prospective trials, although Dr. Jubin did show few trials that are ongoing at the moment and might come up in future. But as of now, it's very unlikely that metformin is going to undergo a robust cardiovascular outcome trial anytime soon. So metformin's current role as a foundation therapy for newly diagnosed individuals is now severely challenged, and there is increasing emphasis to transition existing algorithms from an approach which is based solely on treating HbA1c targets to a more comprehensive strategy targeting additional patient factors and especially giving organ protection. Also, there are other limitations that we were talking about. Anyone with the eGFR less than 30, and it's not uncommon in India that you see patients who are in advanced stages of CKD who land up in your clinical practice with a very low eGFR, and there is hardly any scope to introduce metformin at that point of time. GI adverse events are typically encountered with metformin, and we know that the Indian individuals especially have this issue, and many of your patients after being started on metformin will come and complain to you about diarrhea, nausea, flatulence, indigestion, vomiting, etc. And that will lead on to subsequently discontinuing or reducing the dose of metformin. And some of them, as we had mentioned earlier, are true metformin intolerant, and you can't just give metformin to them. Metformin also causes vitamin B12 deficiency by reducing vitamin B12 absorption, and it has been reported that an average of 6 to 30% of the patients could actually show vitamin B12 deficiency due to metformin use. In addition, some studies have reported that serum vitamin B12 were inversely related to the duration and dose of metformin use. Long-term metformin therapy, we have already talked about this. Skipping this earlier stepwise approach, this is the conventional method. Initially lifestyle and diet, followed by, say, metformin monotherapy. You wait for treatment failure, you combine, and then you initiate insulin, and then you subsequently up-titrate, intensify the insulin, and that's how the story went. But we know from this Dr. Kamlesh Kunti's study that unless you're hitting diabetes really hard and getting diabetes to the target levels within the very first year of life, you subsequently consequently increase the chances of 5-year cardiovascular risk significantly, and the cardiac morbidity and mortality significantly increases. And this is coming from Ralph DiFronzo, who thinks that you should be using multiple drugs in combinations if required, based on the ominous update and the pathophysiology of the disease, and it needs to be started early. So I'm not sort of refuting metformin at this point of time, but what I'm trying to say is that metformin is probably just not enough when you have a very high starting HbA1c and you need to do more. So this is AC 2020 guidelines, and you can see in here if the entry A1C is more than 7.5 and up to 9, you're absolutely fine using a dual therapy or even a triple therapy if necessary. And you can see all the choices in here. And I again want to highlight that independent of the glycemic control, if there is established a high atherosclerotic cardiovascular risk or established CKD, then recommendation is to start off with Sglt2 inhibitor and a GLP-1 receptor analog ahead of metformin. Again, 80 standards of care, and you see the data: primary heart failure outcome, primary renal outcome study, prevention of risk worsening of heart failure and CV death. We have data with DAPA, EMPA, CANA, and we have already been talking about this ample number of times from the beginning, that in those patients with a background of atherosclerotic cardiovascular disease, heart failure, CKD, you need to consider Sglt2 inhibitors and GLP-1 receptor analogs ahead of metformin. And Dr. Jubin just did my life a lot easier by showing the data that was being shown. An addition of metformin just offset the benefit that came from using Sglt2 inhibitors at large, and that was coming from the EMPERAGE and CANVAS subset study. And of course, you have to remember that anything that targets glycemia is, of course, going to be beneficial in terms of reducing the microvascular complications, but that's not good enough to control the macrovascular complications that arises, and you need to have mechanistic benefits that arises from the new molecules, and we have evidence for that, and you need to bring them in place, because what I want to say is that Dr. Jubin was just trying to grab onto a straw, and this is what a dying man does when he tries to save himself, and whatever reasons he had given in favor of metformin is at this point of time seem very unreasonable to me. So take-home points: it is incorrect to give a blanket therapy to everyone because one shoe doesn't fit all. So just using metformin for everyone and waiting until treatment failure happens with metformin is just not reasonable based on all the recent evidences that we have. Up to 1/3 of the patients cannot tolerate full dose of metformin, and because of the GI side effects, and the dose needs to be titrated as well. And also we have now growing strong evidences in favor of Sglt2 inhibitors and incretin-based therapies. So the answer is metformin the choice of therapy for all the type 2 diabetic patients at initiation? And the answer is a clear no. So again, I understand that, to embrace a new idea is always challenging. And you know about Galileo Galilei and how he was prosecuted for bringing in a new idea when the world used to think in a different way. And finally, I just want to conclude that these were the older generation phones, which used to work absolutely fine when you wanted to speak, but now you have the new generation phones. And while we are in an era where we are doing teleconsultations or our kids are doing schools from home, try giving one of these older devices to them, and let's see whether it serves the purpose when you have a smartphone like this. So thank you so much, and I stop sharing here.
Thank you, Dr. Supratik. I would now like to invite Professor Jacob for his rebuttal. Professor Jacob, sir, please.
I don't have any slides, but I am very, very pleased that Dr. Supratik did not show ADA-EASD guideline. As a bona fide endocrinologist, he decided to go with the ESC guidelines of 2019, which has been, for the last 2 years, not been accepted by the ADA or EASD. So I'm very glad that he went with the cardiologist. He did not go with the endocrinologist. The second thing that I want to highlight to him, that the VA impact study is actually a cardiovascular outcome trial with metformin. And it is a fairly large study. Only difference being, because it is metformin versus placebo, they are not including patients with diabetes. They are recruiting patients with pre-diabetes. But my guess is it is going to give us the same information about the cardiovascular benefits of metformin. And that is a very large study. And you have to remember, some of the most game-changing studies have not come where it was commercially, the sponsors were commercially. UKPDS, DCCT, all have come from investigator. Even the VA system, that is the Veterans Health Administration system in the US, has given us a fair number of good studies which we have used in our practice. So I think VA impact is a very large study which is going to look at metformin as the first line drug in terms of cardiovascular outcomes, comparing them with placebo. Other thing, Dr. Supratik, you did mention about side effects of metformin. I did not mention about any side effects of Sglt2 inhibitors or GLP-1 analogs. Your options are these two. I'm sure it is either GLP-1 analog or Sglt2 inhibitors. And I'm sure the whole audience knows that the GI side effects of GLP-1 are definitely not going to compare to the GI side effects of metformin. Even in all your studies, the cardiovascular outcome studies with GLP-1 analogs and with Sglt2, you said 1/3 of patients could not tolerate metformin. You see almost 75%, 80% of them are on metformin. So that means maybe 10%, 15%. Many of them are contraindicated because of heart failure or other issues, not because they could not tolerate. So it's definitely 1/3 of patients are not going to not tolerate metformin. Maybe about 1 in 10 or 1 in 10% patient may not tolerate metformin. So side effect profile, I think metformin is a known devil. We know what the side effects are. With Sglt2 inhibitors, we are finding new side effects. We are finding With one of them, we find fractures, one of them, we find amputation. Suddenly we have Fournier's gangrene. With metformin, we know the side effects, GI side effects, they're not there. If it's not there, it is not going to come back. B12 deficiency may be there. Give them some B12 supplements. There are no hidden side effects because we have had this drug, though we don't know its mechanism of action, we've had this drugs for more than 68 years as a pharmaceutical product and more than 300 years as a herb. So that is the confidence that we have with metformin. So I think these were the few issues that I wanted to make. And I also wanted to know Dr. Supratik. He very clearly also mentioned from my study that metformin is mitigating the benefits of Sglt2 inhibitor. It is not just mitigating the benefit of Sglt2 in EMPA and CANVAS. Also in LEADER, it is mitigating the effect of GLP-1 to a much significant effect than Sglt2. Is it mitigating the effect, or is metformin providing cardiovascular benefit that these drugs are not able to compare with? So that is, I think, still open to question. And I know that the Sglt2 inhibitors, the GLP-1 have a set of what we call extra glycemic benefit in terms of heart failure, in terms of renal outcomes. But I think the extra glycemic benefits of metformin are going to be much, much more. I mean, I believe that calorie restriction, we know that calorie restriction in large mammals like the macaw monkeys have shown longevity. We saw metformin showing longevity in small nematodes. I'm sure metformin is also going to show longevity. And that is the reason why I believe if they can tolerate, all patients with type 2 diabetes should be on metformin, regardless of whether they have atherosclerotic cardiovascular disease. Obviously, if their CKD and their eGFR is less than 30, you cannot prescribe metformin. And I'm sure Dr. Supratik does not prescribe Sglt2 inhibitors as well for them. So there are limitations, but as far as possible, I would think that all patients with type 2 diabetes, unless there are something that contraindicates, should be on metformin. And I think I'll keep holding to that. And hopefully for this, in the next few years, we'll get more and more information that may keep up with my view. Thank you.
Thank you, Professor Jacob. Dr. Supratik, your final points to counter Professor Jacob.
Yeah, so again, I don't have any slides, of course, and I'm happy to take on board everything that Dr. Jubin had said. Now, I don't know whether we should be proud of the fact that we are not embracing the change as aggressively as our cardiologists and the nephrologist colleagues are, or whether we should be very proud of that fact or not. But secondly, as we are saying that we are awaiting the trials, so if when we have the cardiovascular outcome trials with metformin in place, of course, then again, we'll have this debate. But as of now, standing today, whatever evidences that we have is not favoring use of metformin in all patients coming to your clinic being initiated on an OHA or for any anti-diabetic agent for that matter. So if you try to convince me today, I'll not be convinced at all. And I would also want to ask the viewers and to keep a hand on their chest and ask themselves, are there patients in your clinical practice where you do not use metformin? Does metformin fit all shoes or not? With this, I conclude and I would not take it further. So thank you.
Thank you, Dr. Supratik. Thank you, Professor Jacob. It is a very interesting debate. Now, I would like to invite my co-chair, Dr. Deep Datta, for giving his closing remarks and his final opinion. Deepta, please.
Thank you so much. It was, as always, mesmerizing listening to both the speakers, Dr. Jubin and Dr. Supratik. Both spoke so well and eloquently. I think both have placed their points beautifully. I think the evidence for metformin is there and it is increasing day by day. The concept of longevity is very important. It's something which promotes life, survival, and gives a quality of life. Dr. Supratik also highlighted his key point was that all. I think that's very important. Not for all. Yes, we will have individualization is the key, is the way forward. We will have patients who will not tolerate metformin, who will have some unexpected side effects. We rarely have patients who have lost even 10 or 15 kilos with metformin, and that's really concerning for them, right? So I think individualization is the key. We will still have some odd patients who will not tolerate metformin. Other than that, I think metformin as of today continues to be the backbone of managing type 2 diabetes. All the great molecules of Sglt2 inhibitors and GLP-1 analogs, they're all CVOTs. They were generated on the backbone of patients who were already receiving metformin. So both the speakers spoke eloquently. Now we know that the key points which have taken, I think the audience have taken the key points. I think individualization is the key. So there is no role of metformin going out of practice. Newer agents are coming. They are making their place. I think individualization and going for a patient-centered therapy would be the way forward. A big thanks to both the speakers for speaking so well. Hats off to you.
Thank you so much. And
thank you.
Just wanted to say we are in the same team when it comes to the patient's best interest, and we are all fighting for their best quality of life. So thank you again. It was a pleasure, Dr. Jupit. And thank you, Chair.
Thank you.
Dr. Abhitish. Thank you.
Thank you so much. Thank you.
Dr. Amrita. Thank you. You did a brilliant job, both of you. Thank you. Thank you, Doctor. Thanks again.
Thank you. Yeah. Thank you, Deepta, as well. So with this, we come to the end of the sessions for the Bdcon 2021. This was the debate was the last session for today's evening. We had a very exciting set of sessions. We had very nice speakers who spoke very well. I wholeheartedly thank all the speakers and the chairpersons and all the delegates also who took active participation in making this Bdcon 2021 a success. I would now like to hand over the proceedings to Ms. Anupreksha Biswas to deliver the formal vote of thanks. Ms. Biswas, kindly take over the proceedings. It's over to you.
Thank you. Thank you so much, sir. Good evening, everyone. I feel humbled to have been successfully completed the 6th year of Bengal Diabetes Conference, Bdcon 2021, with the grace of Padma Shri Dr. Shushoban Banerjee. I express my gratitude to all the esteemed speakers and chairpersons for having such interactive and informative academic sessions. Thank you to all the Bengal Diabetes Foundation members who have been in full support to put up the conference this year as well. Thank you to Cubics Events and Conferences Private Limited for their hard work in planning and managing the event beautifully on the virtual platform. Also, a big thank you to all the sponsors for their constant belief and support. Novo Nordisk India, Novartis Healthcare Private Limited, Boehringer Ingelheim, Roche Diabetes Care India, Sanofi India, Lupin Limited, USV Private Limited, Torrent Pharmaceuticals, Intas, Sun Pharma, Jarun Pharmaceuticals Juicer, Vitabolic. Once again, a heartfelt thank you to each and every one for being a part of Bengal Diabetes Conference 2021. Thank you, and I hope everybody has a wonderful year ahead. Take care. Good night.